Yeah, good morning to all, ISMconians. This is Dr. Nurul, your host and organizing chairman. Am I audible to all? Can anybody unmute and give me whether I'm audible or not?
Yes, sir, you're audible.
Yeah. Okay. Thank you. Dr. Viva, are you there?
Yes, I'm here.
So Dr. Viva, I have made you co-host. Can you first, share your slide once we'll check it and then we will start our program.
Okay.
Yes.
Uh, are
Yeah,
you
it's a
able to see?
it's a visible. It's visible, but it is not in a slide show mode actually.
Okay, okay.
Presentation
I'm
mode.
I'm doing.
Yes, yes, or it's a slide show. So there is a one announcement. Actually, there is some technical glitch happen. It usually not happening with the programs which is being conducted by National Health Academy and MedSkill. But somehow late we detected there is some issue, and so there is a problem in sending the emails as well as the message on the WhatsApp. So I'm pretty sure that my have team tried to improvise their function and they have shared the email to everybody and WhatsApped as well, so that everyone is getting their email. Anybody who is not getting, definitely they will call me and I will share it to them. So welcome to all this International Sleep Medicine Congress. This is Dr. Nurul. I am the organizing chairman of this, prestigious program. This is our third episode. We started it in 2022, where, we did our program with prominent speakers. We, made a family and we started this program and we picked up this because in India, what we are getting that this is slowly moving because I have, met with experts and all and this specialty is progressing but in a very slow and very slow pace actually, and people are not much aware about that. So for making this specialty in a awareness in the general public, they started this uh, you know this event in a virtual way. There are many programs which is happening across India. The All Institute of Medical Sciences, they are conducting their programs. There are other organizations related to sleep medicine. There are two, three prominent bodies who are conducting those program, and the programs are overlapping. So that's why we have the problem with speakers as well. The speakers started in a beginning, they have given the approval that they would be available, but somehow they are invited in other programs. So this is the problem with speakers, that we are not getting many speakers. If we talk about the sleep, incidence of sleep, disorder in India. So India is the capital of the sleep disorder problem. We have 10 crores people. Somehow they have the problem of insomnia and OSA, obstructive sleep apnea, a problem. And it is more prominent in male, actually, the 14% the prevalence in men and 5% in a woman. So you understand that what sleep is, very important because, we are getting the, daily newspapers and Times of India and many journals and all. They are saying that even, the kids are not getting a proper sleep and all, and they are not performing well in their examination. They are, sleeping in their classrooms and all. So, the sleep is related to, the problems which, multiple things, the decreased quality of life, hypertension, multiple, depressions, stress, etc. related to this. We have, the heart problem. So the multiple problems are associated with sleeps, and it's a multidisciplinary, specialty where the people who is from, chest specialist, respiratory pulmonologist, ENT surgeon, orthodontist, psychiatrists, neurologists, all are coming together and solving the issue of the sleep disorder. So, not taking much time, we have our first speaker, Dr. Viva Gangwar, who is still who is with us in the meeting room. So we'll start with our program with Dr. Viva Gangwar. She is She is professor in Department of Physiology, Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, UP. And she is going to talk on, the pathology, physiology and epidemiology of sleep. So before going, to start your program, Dr. Viva, could you please give your brief introduction, because it is better that, what point you would like to highlight so that our audience will correlate well. So I requesting you to give your brief introduction before starting your presentation. Over to you, Dr. Viva. Your, slides are visible and you are audible.
Thank you, Dr. Nurul. So, as Dr. Nurul has given my brief introduction, I am Dr. Vibha Gangwar, Professor Junior Grade in the Department of Physiology in Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, UP. And I have been working here for the last 8 years, but total experience of research and teaching in the field of physiology is about 17 years. So I have done so many works on exercise physiology, but sleep I have started recently, circadian rhythm and sleep. So thank you, Dr. Nurul, for giving me opportunity to speak on this special topic that is very pertinent to today's scenario. So today's topic of my talk is sleep physiology, pathophysiology, and epidemiology. So I just want to introduce all of you about what is sleep, what is its physiology, and what happens if we don't take proper sleep. So sleep can be defined as a state of unconsciousness from which a person can be aroused by sensory or other stimuli. But as the definition says, it is a state of unconsciousness, but it is not simply the state of unconsciousness. It is an active, regulated, and metabolically distinct state, which is essential for health and well-being. So sleep is a universal need of all higher human forms, including humans, absence of which has serious physiological consequences. We humans spend about 1/3 of their life as asleep. So it is very important to know about what is sleep and what happens during sleep. And if we don't take proper sleep, adequate sleep, what will happen to our health? So why sleep is important? First, we should know why sleep is important. Sleep, what are its functions? It restores the normal brain activity. It is essential for the neural maturation. It also facilitates the learning and memory. It is very important for cognition. If we don't take appropriate sleep, adequate sleep, cognition is impaired, and chances of injuries, accidents are very much if in inadequate sleep. And there is conservation of the metabolic energy during sleep, which is essential for our bodybuilding. If we don't take sleep, if there is sleep deprivation, then what will happen? So sleep deprivation may be acute sleep deprivation or chronic sleep deprivation. So if there is acute sleep deprivation, our body just to recover that sleep which is deprived. So there are 3 phases of this recovery of the sleep. First recovery night, second recovery night, and third recovery night. And after 3 recovery nights, our sleep, what sleep was deprived, recovery takes place. So during the first recovery night, what happens? Sleep latency becomes shorter. N1, N2 stage becomes less. Duration of N1, N2 stage decreases. Total sleep time increases, and percentage of the N3 stage. What are these stages? I will tell you just after this slide. So percentage of N3 increases and REM sleep percentage decreases. In the second recovery night, most of the recovery occurs during the first recovery night. In the second recovery night, what is left, that is the stage R. Stage R, in the first recovery night, it was decreased, but in the second recovery night, it increases. The total sleep time still increased, and N3 stage becomes normal of the total sleep time, which was increased in the first recovery night. And in the third recovery night, sleep variable approaches towards normal. All sleep variables becomes normal. So this is for the acute sleep deprivation. So body just try to recover that sleep which was deprived. But if there is longer period of deprivation, chronic sleep deprivation, acute, when we say acute, it is less than 24 hours, and if we say chronic sleep deprivation, it is for long period, for days, for weeks. So chronic sleep deprivation affects our health. What are the health effects of the chronic sleep deprivation? It is the attention lapses, increased level of ghrelin, increased level of cortisol, norepinephrine, insulin resistance occurs. There is decreased threshold for the seizure, pain threshold decreases, and cognition also decreases, and there is decreased level of the leptin. So these are the consequences of acute and chronic sleep deprivation. Now, sleep architecture, the general organization, what is the normal architecture of our sleep? So whole of the sleep can be divided into two types. One is non-REM sleep, that is non-rapid eye movement sleep, and the second is rapid eye movement sleep, that is REM sleep, non-REM and REM sleep. This non-REM sleep constitute about 75 to 80% of the total sleep, while REM sleep constitute 20 to 25% of the total sleep time. And both these phases occur cyclically, alternate each other during the whole of the sleep episode. One REM and one non-REM episode constitute one sleep cycle. So this, in one episode of the sleep, various stages occurs. What are these stages? This is classification of the sleep staging according to the American Academy of the Sleep Medicine. So American Academy of the Sleep Medicine divided the whole of the sleep into various stages as per the age. So age can be divided into three categories. First 2 months of the life, then 2 months to 18 years of the life, that is pediatric rule applies, and adult rule applies more than 18 years of age. In less than 2 months of age, after wake stage, the non-REM stage occurs, and then REM stage occurs, and one more stage, there is transitional stage, transition between the REM and non-REM. And this constitute non-REM, REM, and transition stage constitute one cycle. In 2 months to 18 years of age, non-REM further, you can see in the first 2 months of the life, non-REM stage is not subdivided into various stages, but after 2 months, it is divided into four stages: N1, N2, N3, and stage N. It is, if we cannot differentiate between N1, N2, N3, then we say it N, and stage REM. And in adults, there are non-REM and REM. Non-REM is divided into N1, N2, N3, and no stage N. These stages of the non-REM sleep can be distinctly divided into these three: N1, N2, and 3. So these are the stages according to the AASM classification. So I told you that this non-REM and REM, one REM and one non-REM constitute one sleep cycle. This non-REM is divided into N1, N2, and 3. This is for adults. So REM, sleep starts from here, that is from the N1 in adults, N1, then N2, then N3, and then REM. And this whole period of one non-REM and one REM constitute one sleep cycle. Sleep architecture in adults. What is this, and what is the sleep architecture in pediatrics? So in adults, if we talk about the adults, the sleep cycle begins with a short period of N1, as you saw in this slide, N1. N1 starts first, of the non-REM stage, then progresses through the N2, followed by N3, and finally, after all the stages of non-REM, final stage is REM. Average length of this one cycle, that is non-REM and REM sleep cycle, is about 90 to 120 minutes. REM sleep increases. Initially, the period of REM is very less, but as the night progresses, as the sleep progresses, REM sleep increases, and it is longest in the last one third of the sleep episode. And if we talk about the various stages of the non-REM sleep, so we can see in this diagram also that N2 is longest. N2 stage is the longest and N1 is shortest. So stage 2, that is N2, accounts for the majority of the non-REM sleep. Before we proceed further about the various stages of the sleep, we should know what are the waveforms. If we want to know about the EEG changes, if we record the polysomnography, we see the changes in the EEG. So we should know what are the waveforms which happens during sleep. So in sleep, these different types of waves occurs. These are alpha waves, low amplitude mixed frequency waves, then sleep spindles, K complex, slow waves, and sawtooth waves. So these all type of waves vary according to their amplitude, frequency, shape, distribution, and duration. So amplitude of the alpha waves, amplitude of neither wave is defined except slow wave, which amplitude is more than 75 microvolt. It should be 75 microvolt, then only we say that it is a slow wave. Frequency is variable among the different waves. In alpha waves, it is 8 to 13 hertz. In low amplitude mixed frequency, that is LAMF. These are mixed frequency waves and low amplitude, that in short we can say LAMF. So its frequency is about 4 to 7 hertz. Sleep spindle frequency is 11 to 16 hertz. Frequency of K complex is less than 2 hertz, and slow wave frequency is 0.5 to 2 hertz. Sawtooth wave, their appearance is like sawtooth. Its frequency is 2 to 6 hertz. Shape of the alpha wave is regular and sinusoidal. LAMF, it is irregular. All the things are irregular. It is low frequency, mixed frequency, low amplitude, irregular. Sleep spindle also sinusoidal in shape. K complex is typical in its presentation. First negative deflection, then followed by positive deflection. So this constitutes one K complex. First negative followed by positive deflection. Slow waves, a shape is not defined. Any shape here they can take. Sawtooth, like sawtooth appearance. Distribution of these waves. If we want to see which type of wave will come in which lead, if we record the polysomnography, if we see the EEG, if we record the EEG, so different leads we apply in this EEG, and different types of wave prominently occur in different leads. In alpha waves occur prominently in the occipital leads. LAMF in all the EEG leads. It occurs in all the EEG leads. Sleep spindle, especially in the central EEG. K complex in the frontal EEG leads. Slow waves in the frontal, and sawtooth wave also in the central EEG lead. Duration not defined for anything except sleep spindle and K complex. Their duration should be more than 0.5 seconds. So I told you about the leads. This is the diagram showing the placement of the leads during EEG recording. It is called 10-20 system of the EEG leads. Here you can see the various type of electrodes placed on this scalp. It is called 10-20 system because some electrodes are placed at the 10% of the total distance and some electrodes are placed at the 20% of the total distance. So it is called 10-20 system of the EEG. So here this point is mesion, this is emion, posterior most point, this is anterior point, and these two electrodes are kept on the mastoid process. So and in the front portion, it is frontal portion. The leads are placed, they are called frontal leads. In the central part, they are called central leads, and the parietal region, they are called parietal leads, and the occipital leads, they are called occipital leads. And in these two leads are in the temporal region, T3 and T4. The odd number and even numbers are given, and also Z, you can see. Z means the leads, the electrodes are kept in the central line, while this is on the left side, odd number, and on the right side, even number. So this is the 10-20 system, and when we record all these leads, then different types of waves occurs prominently in these different electrodes, different leads. So now we will talk about the different stages. What are the different stages? What happens in these stages, and what are the EEG changes in these stages? So first is the non-REM sleep. When sleep begins in the adults, first stage which comes is non-REM sleep. So non-REM sleep is a dreamless sleep, and there is decrease in the peripheral vascular tone and vegetative functions of the body during this non-REM sleep. Also, blood pressure, respiratory rate, and basal metabolic rate decreases. So first is the N1 stage of the non-REM sleep. N1 stage is very short. It occurs for about 1 to 7 minutes in the initial cycle and constitute only 2 to 5% of the total sleep time. Here, EEG during N1 stage, you can see it is low amplitude, mixed frequency. These are the, on the left side, you can see the leads, frontal, central, occipital. So, and low amplitude mixed frequency waves occurs in all the leads, low amplitude and mixed frequency. So, in some part frequency is higher, some part frequency is lower. So it is mixed frequency EEG waves. And this stage, N1 stage, is for light sleep. It can be easily interrupted by the disrupted noise. Then second stage is N2 stage, which accounts for 45 to 55% of the total sleep time. It is about 10 to 25 minute duration in the initial cycle, but this N2 stage increases with each successive cycle, and it is quite deeper than the N1 stage. So it requires more intense stimuli than the N1 to awaken. Here you can see in EEG recording, N2 stage characterized by two things, that is sleep spindle and K complexes. If sleep spindle and K complexes are coming in any stage, you can blindly say it is N2 stage. Here, this is the sleep spindle. You can see this is whole of the LAMF activity is spread in all the leads, but in these LAMF activity, in between some burst of the high frequency waves, that is alpha waves occurs. This is the sleep spindle. The sleep spindle and K complex. This is the K complex. This is sleep spindle, LAMF activity, and interrupted by sleep spindle. Burst of the alpha activity is called sleep spindle, and this is the K complex, that is a negative deflection. In all the electrophysiology recordings, the negative deflections comes upwards and positive deflections come downwards. So it is initial negative deflection followed by positive deflection. This whole complex is K complex. So K complex and sleep spindle are the characteristic features of the N2 stage. Then next stage, that is N3. N3 is the deep sleep. It is the restful sleep. It is also known as slow wave sleep because slow waves, its characteristic feature is slow wave. Slow waves occur in this N3 sleep. The slow wave frequency is much lower, but the amplitude is much higher. I told you in the beginning. This is the slow wave. You can see these are two slow waves. You can see these two slow waves. Amplitude is very high. It is more, if we measure the amplitude, it is more than 75 microvolt, and the duration is more than 0.5 seconds. So most of it occurs during the first third of night, that is N3 stage, first third of the night. And as the sleep duration increases, N3 stage becomes less. So EEG shows high voltage, slow wave activity during this stage. Now, the next is after the non-REM sleep, next stage occurs, that is REM sleep. REM sleep is also known as paradoxical sleep. Paradoxical, why it is called paradoxical? Because the brain usually this is a stage of sleep. All the functions, all the body functions should decrease, but in REM sleep, brain is highly active, body muscles becomes active, and our body is quite active during the sleep, so it is called paradoxical sleep. It is a state of sleep but body is active, that's why it is called paradoxical sleep. During the initial cycle, REM period is very less, that is about 1 to 5 minutes, but it becomes progressively prolonged as the sleep episode progresses, and maximum is about 30 minutes. 5 to 30 minutes it ranges, initially less, and in the morning hours the maximum is about 30 minutes. In EEG, REM sleep shows LAMF activity, desynchronized LAMF brain activity. So, other changes which occur during the REM sleep, rapid eye movement. Very particular about the REM sleep, rapid eye movement. REM meaning is rapid eye movements. So rapid eye movement occurs during REM sleep, and also active muscle movements are occurring. That's why it is called paradoxical sleep and REM sleep. This REM sleep associated with the dreaming. Person is more difficult to arouse by the sensory stimuli than the non-REM sleep. Dreams usually occur during the REM sleep, but it can also occur in the non-REM sleep. But if dreams occurs in the non-REM sleep, they are not remembered, they are not consolidated in the memory. So dreams which we can recollect, they occur in the REM sleep. People usually awaken spontaneously in the morning during the REM episode. Muscle tone throughout the body decreases during the REM sleep. Heart rate, respiratory rate becomes irregular, but brain is highly active. The EEG activity is desynchronized, so it is also known as desynchronized sleep. So this is the diagram showing all the stages of the sleep. First, you can see the awake. When the person is awake, there is a alpha activity. Person goes to bed but not sleeping. He is drowsy. Alpha waves occur. These are sinusoidal waves which happen during this drowsy state. Then when person goes to sleep, first stage that appears is N1. N1, I told you that is LAMF activity, and then N2 stage characterized by sleep spindle and K complexes. Then N3 stage characterized by the slow waves. Slow waves are clearly seen here, high amplitude, more than 75 microvolt, and frequency. Their duration is more than 0.5 seconds. This REM sleep is characterized by LAMF activity, low amplitude mixed frequency wave. Its amplitude is very less than the N1. So these are all stages and their EEG characteristics. Now, what are the different physiological changes which occur during sleep? There is a comparison of a non-REM sleep and REM sleep. REM sleep is it is a stage of quite active stage, REM sleep. So what happens in the non-REM and what happens in the REM sleep? It is a comparison. So brain activity, I told you, in non-REM sleep, brain activity decreases from the wakefulness, but in REM sleep, brain is quite active. What increases? Motor and sensory activity in the brain increases, while other areas are similar to non-REM. Heart rate in non-REM sleep slows down from the wakefulness, while in REM sleep, the heart rate increases and varies in comparison to the non-REM. Blood pressure, non-REM sleep decreases, but in REM sleep, it increases. Sympathetic activity in non-REM sleep decreases, but in REM sleep, it increases significantly. The muscle tone in REM sleep, muscle tone decreases, and non-REM sleep is similar muscle tone as wakefulness. Blood flow to the brain decreases from the wakefulness in non-REM sleep, while it increases in the REM sleep. Respiration decreases in the non-REM sleep, but it increases in the REM sleep. Airway resistance increases during sleep increases. but in non-REM sleep, little less increase than the REM sleep. So, and obstructive sleep apnea and all these disorders, airway resistance increases in the REM sleep. This is the basis for further diagnosis and treatment for the obstructive sleep apnea. Some other physiological changes during sleep, other than these changes, which we have discussed right now. Cardiovascular changes, brief increase in the blood pressure and heart rate. We discussed here in the slide that the heart rate, blood pressure, all these decreases in the non-REM sleep, but it increases in the REM sleep. But during the sleep spindle and K complex and sleep spindle is the state when sympathetic activity increases. So usually sympathetic activity is down during the non-REM sleep, but during the sleep spindle and K complexes, sympathetic activity increases. So blood pressure and heart rate increases. There is a brief increase in the blood pressure and heart rate during K complex and sleep spindle. Also during arousals and large body movements which are happening in the during the sleep. So there is increased risk of myocardial infarction in the morning due to sharp increase in the heart rate and blood pressure that accompany awakening. Autonomic activity, we have already discussed, that is, there is a burst of sympathetic nerve activity during non-REM sleep when there is K complex and sleep spindle. Renal system, there is decreased excretion of the sodium, potassium, chloride, and calcium during sleep that allow for the more concentrated and reduced urine flow. In endocrine system, various hormonal changes also occur. Growth hormone secretion typically takes place during the first few hours after sleep onset and generally occurs during the slow wave sleep. Thyroid hormone secretion takes place in the late evening, while melatonin secretion are suppressed by the light. It increases during the sleep. But it is the melatonin which is responsible for our circadian rhythm entrainment. Now, sleep-wake regulation. How these sleep and wake cycle stages they are regulated. So it is the interplay between two major processes, that is process S and process C. Process S is the process which promotes sleep, while process C maintains wakefulness. Process S homeostatic. It is the homeostatic drive for the sleep, and need for the this process S, that is sleep, accumulates over the day, and it peaks just before the bedtime at night. This process S dissipate throughout the night when we take the restful sleep. Process C is the wake promoting process. It is regulated by the circadian system. Process C builds across the day, serving to counteract the process S. It promotes wakefulness and alertness. Process C begins to decline at the bedtime and serving to enhance the sleep consolidation. Assist in the keeping sleep wakefulness cycle coordinated with the environmental light-dark cycle. When we take an adequate night's rest, the homeostatic drive for sleep is reduced. The circadian waking drive begins to increase and the cycle starts over. Process C also works to consolidate sleep and wakefulness into fairly distinct episodes. If process C is absent, then total sleep time remains the same, but it is not entering to the light-dark cycle. It is randomly distributed over the day and night. Now, what are the sleep-generating systems in the brainstem? Sleep-generating systems are present in the brainstem. The sleep process S is regulated by the neurons in preoptic area of the hypothalamus. This preoptic area contains molecules that inhibit neuronal communication, turn off the arousal system during sleep. It also gets input from the other regions, that is lower brainstem, which relay information about the state of the body, then emotional and cognitive areas of the forebrain, and circadian system. That is suprachiasmatic nucleus, which allow the wake sleep system to synchronize with the external day-night cycle. It is the sleep generating system. Now, there is also wake generating system in the brainstem. What is this wake generating? It is the ascending arousal system from the brainstem to the higher center, which activates forebrain structures to maintain wakefulness. There are two pathways for this wake generating system. First is cholinergic neurons present in the upper pons, which goes to the thalamus. And second is the neuron in the upper brainstem, which goes to first hypothalamus, then basal forebrain, and finally to the cerebral cortex. So these are the wake generating systems in the brainstem. Now, sleep pattern changes with the age. With age, the sleep pattern changes. Initially, in the newborn, it is something different pattern. Then, as the child grows older, also in the old age, the sleep pattern varies. So, in the newborn, if we see the newborn EEG recording or sleep pattern, there is not a particular N1, N2, N3 stage and then RAM stage. It is just a trace alternate pattern. What is this trace alternate pattern? It is the high amplitude burst alternating with the theta activity. It is not differentiated into various stages. Non-RAM poorly differentiated, but sleep cycle starts with the RAM sleep. This is the characteristic feature in the newborn, that sleep cycle starts with the RAM sleep, while in adult sleep cycle starts with the non-RAM sleep. RAM sleep constitute about the 50% of the total sleep cycle. Total sleep time is about 16 to 18 hours spread over the 24 hours. It is not entering into the light dark cycle. It is spread over all over the 24 hours. Sleep cycle lasts for about 45 to 60 minutes, while in adults it lasts for about 90 to 120 minutes. Sleep periods last for about 3 to 4 hours. Circadian rhythm begins to arise around the 2 to 3 months of age. After this 3 months of the age, the sleep becomes consolidated, and usually the baby sleep in the night, started sleeping, increase sleeping during the night and decrease sleeping during the day. It leads to the sleep consolidation that manifests in the greater duration of the wakefulness during the day and longer periods of the sleep at night. At 3 months, the circadian rhythm fully develops. Sleep cycle onset occurs with the non-REM sleep. This is the milestone. This is the landmark. At the 3 months, sleep cycle onset becomes with the non-REM sleep, while before 3 months, the sleep cycle starts with the REM sleep. Now, in the young children, the sleep amount decreases as the child grows older. Decreased daytime napping and more likely to have nightmares, which usually disrupt sleep. In adolescents, there is complete transition to the adult sleep pattern, which they require about 9 to 10 hours of the sleep each night. Slow wave sleep and sleep latency progressively declines. Sleep latency means the patient when goes to bed, and the duration from the going to bed to the onset of the sleep. This is for sleep latency. Initially, it is more, but in adolescents, it declines. In elderly people, when the person grows older, the stage N3 decreases. N3 is the deep sleep. It is the restful sleep. So it decreases with age. In the elderly people, it decreases. Number of arousals or increases. Sleep requirement does not decrease, but the elderly people sleep for lesser time. Circadian phase also advances, means they sleep early in the night and wake early in the morning. This is circadian phase advancement. Now, what are the sleep disorders? Sleep loss and sleep disorders among the most common yet frequently overlooked and rarely treatable health problems. About 50 to 70 million Americans chronically suffers from the disorders of the sleep and wakefulness. If we see the sleep disorder prevalence in the India, most common, that is insomnia, OSA, and restless, various types of sleep disorders happen. It is about more than 90 types of sleep disorders, but here we are talking most common, that is insomnia, about 25.7%, OSA 37.4%, and restless leg syndrome about 10.6% in India. This is the classification of the sleep disorders given by American Academy of the Sleep Medicine. So there are 6 broad categories of sleep disorders. First is insomnia, the sleep-related breathing disorders, central disorders of the hypersomnolence, circadian sleep-wake disorders, parasomnia, and sleep-related movement disorders. First is insomnia. Insomnia is defined by the International Classification of the Sleep Disorder, third edition, that is ICSD-3, as difficulty in initiating sleep, maintaining sleep, waking up before the desired time, resistance to go to bed at adequate time. All these symptoms, if they are occurring, it is called insomnia, and these symptoms can't be explained by any other disorder. There are 3 subtypes of insomnia. First is chronic insomnia, second is short-term insomnia, and third is short sleeper. So chronic insomnia, we say if symptoms, all these symptoms, which we have discussed earlier, this is difficulty in initiating sleep, maintaining sleep, and difficulty in waking up before the desired time. So all these symptoms is present for at least 3 months, for at least 3 times per week, then we call it as chronic insomnia. Shorter insomnia is called when symptoms present for less than 3 months. Short sleeper is a normal physiological condition when the person sleeps less than 6 hours sleep per night. It is called short sleeper. Sleep-related breathing disorders are classified as obstructive sleep apnea, central sleep apnea. I'm not going into details of all these disorders because time is short. I'm just introducing all the respected who have joined here just to what are the various sleep disorders. So sleep-related breathing disorders are classified as obstructive sleep apnea, central sleep apnea, sleep-related hypoventilation disorder, and sleep-related hypoxemia disorder. Obstructive sleep apnea, when there is partial or complete obstruction in the airway despite continued respiratory effort. This is called obstructive sleep apnea. Central sleep apnea, in the central drive for the respiration is absent and period of apnea occurs during the sleep. No obstruction of the airway in the central sleep apnea. Sleep-related hypoventilation, and then sleep-related hypoxemia. Hypoxemia, then when the oxygen saturation decreases, how much decreases? It is less than 88% in the adult and less than 90% in the children. Now, central disorders of the hypersomnolence. Hypersomnolence means excessive sleepiness, but it is excessive daytime sleepiness, not attributable to any other sleep disorder causing disturbed sleep or normal circadian rhythm. Its subtypes are insufficient sleep syndrome, narcolepsy, idiopathic hypersomnia, clean living syndrome, and long sleepers. So these are the what are these disorders of the hypersomnolence? Insufficient sleep syndrome is decreased sleep time leading to daytime lapses. In night, there is decreased sleep time leading to the daytime lapses into sleep and behavior abnormalities. In narcolepsy, some characteristic features occur. It is also excessive daytime sleepiness. What happens in these 3 characteristic features? That is, first is cataplexy, second is sleep paralysis, and third is hypnagogic hallucinations. Cataplexy is sudden loss of muscle tone in the lower limb and jaw drooping when emotionally excited. Sleep paralysis is inability to move on waking up for a few minutes, for a few seconds, and hypnagogic hallucination, that is the hallucination at the sleep onset. Then idiopathic hypersomnia is irresistible attack of daytime sleepiness more than at least 3 months. It is unrefreshing daytime naps during daytime for more than 1 hour. Clean living syndrome is a rare syndrome. It is a long episode of severe sleepiness lasting for several days to weeks, also associated with the cognitive dysfunction, hyperphagia, and hypersexuality. Long sleeper, as short sleeper, it is also a physiological condition. When person sleeps for more than 10 hours in the 24 hours, it is called long sleeper, normal physiological condition. Then circadian rhythm sleep-wake disorders, which is related to circadian rhythm. There are 3 types, not 3 types, there are 5 types for delayed sleep-wake disorders, advanced sleep-wake phase disorder, irregular sleep-wake phase disorder, non-24-hour sleep-wake disorder, shift work disorder, and jet lag disorder. Delayed sleep-wake phase disorder means late bedtime and late waking, late bedtime. This is delayed sleep-wake phase for more than 2 hours. This how much delayed? It is more than 2 hours for the normal desired. Advanced sleep wake phase, tendency to sleep early and wake up early in the morning. Irregular sleep wake phase disorder is recurrent irregular sleep and wake episodes throughout 24-hour period. No particular pattern. Insomnia at night and excessive daytime sleepiness during the daytime. The non-24-hour sleep-wake rhythm disorder, it is intermittent symptom of insomnia or excessive daytime sleepiness caused by the misalignment of the circadian rhythm, and it occurs in the totally blind people. It is not related to this circadian rhythm. Shift-wake disorder. It occurs in the shift workers. It is non-traditional working schedule caused by misalignment of the circadian rhythm. Jet lag disorders happen in those people who travel for multiple time zones, especially after the jet travel. It is circadian rhythm misalignment. Clock time resynchronizes automatically at the rate 1 to 1.5 hours per day per time zone. Parasomnia are undesirable physical events that occur when falling asleep, during sleep, or waking up from the sleep. They are classified as non-REM parasomnia, REM parasomnia, and other parasomnia. Non-REM parasomnias are confusional arousals, sleepwalking, sleep terror, and sleep-related eating disorders. Confusional arousals means patient arouses in between the sleeps, and he is in the confusional state. Sleepwalking, we all know sleepwalking. Sleep terrors are the screams which are associated with the intense fear, and autonomic arousal occur. Autonomic arousal means there is increase in the heart rate, blood pressure, respiration. All this occurs associated with the sleep terrors, screaming. The sleep-related eating disorders, a person arouses during the sleep intermittently, started eating, and he or she also eats some edible substances, also some non-edible substances, whatever. So it is something abnormal, sleep-related eating disorder. Next category, RAM parasomnia. RAM parasomnia classified as RAM-related behavior disorder, nightmares, and recurrent isolated sleep related paralysis. RAM, sleep related behavior disorder, is the abnormal behavior which occur during the RAM sleep. What is this behavior? It can be some sleep related vocalization, some complex motor behaviors. So nightmare is the well remembered dream and dysphoric episodes. But here in the nightmare, it is different from the night terror, but in the sense that autonomic discharge does not occur, or if occurs, it is mild. It is not associated with some violence. But night terror is associated with some motor movements and violence. Displacement from the bed is rare in the nightmare, but patient arouse and get off from the bed during the night terrors. Recurrent isolated sleep-related paralysis is the inability to perform voluntary movements when falling asleep or waking up. Other parasomnia are exploding head syndrome, sleep-related hallucinations, sleep enuresis, parasomnia due to medication or substance use. Exploding head syndrome is the sudden loud noise. A person feels sudden loud noise or explosion in the head. Next category is the movement disorder. Movement disorder classified as restless leg syndrome, periodic limb movement disorders, hypnic jerks. Restless leg syndrome is the irresistible urge to move legs. A person has a circadian preference for the evening or night, and this urge to move legs also occurs during the evening or night. It is associated with some iron deficiency or long during day person has done so much of physical activity, then it happens, restless leg syndrome. Periodic limb movement disorders, the limb movements which happen during the sleep, but we call it periodic limb movement disorder only when these events are more than 5 per hour in children and more than 15 events per hour in adults. Hypnic jerks are the sudden, brief, simultaneous contractions of the body parts which are occurring at the sleep onset. So this was all about the physiology and pathophysiology and slight epidemiology of the sleep. Thank you. Dr. Norul.
Yeah, thanks, Dr. Viva, for giving in-depth the initial the physiology, pathophysiology, and incidence of this sleep disorder. I'm requesting from audience, if you have any question, you can unmute your microphone and ask question right away to Dr. Viva Gangwar. Anyone who want to ask question, they can unmute your microphone, ask the question, or they can type on the chat box as well. If there is any question. Dr. Viva, there is not right question right away. If you are stay with us for a while, maybe we'll take the questions after this the next speaker.
Okay.
Otherwise, whatever the question will arise, will email to you.
Okay.
Thanks for joining us and sparing your valuable time and joining us the International Sleep Medicine Congress. Thanks a lot for giving your precious time. Thank you.
Thank you.
With your permission, Dr. Viva, should we move on to our next speaker?
Yes. Yeah. Sure.
Yeah, so thanks, Dr. Viva. So our next speaker is Dr. Ankur Tanwar. He is a research scholar. Actually, we kept this slot for a paper presentation. So and we connected with Dr. Ankur Tanwar, and he is a research scholar in All India Institute of Ayurveda, New Delhi. And he will throw light that what is Ayurvedic understanding of Nidra is sleep. And it would be very nice that we are getting that what the Ayurveda's take on sleep medicine. Over to you, Dr. Ankur. I think your slides are visible, and you start your presentation.
Thank you, Dr. Norul, sir. Thanks for providing me the opportunity today on Ismcon. Myself, Dr. Ankur Kumar Tanwar. I am doing my MD in Ayurvedic Physiology, Kriya Shai, and currently doing PhD, All India Institute of Ayurveda. Topic of my presentation is Ayurvedic understanding of sleep, Nidra. Ayurveda told Nidra as a sub-pillar of life, as a Triya Upistham. Acharya considered Nidra as one among the three Upistham. Three of them are food, sleep, and control of mind. For the living being in the world, Nidra is an essential phenomena for the maintenance and restoration of both body and mind. Proper maintenance of this factor is truly essential for the health, and any mismanagement can result in the serious and unhealthy state of body and mind. Nidra is a natural urge. Nidra is one among the non-suppressible natural urge. Acharya mentioned Nidra as an essential phenomena which cannot be suppressed. It showed that the Nidra is essential for life and one cannot be suppressed. It Acharya states that delusion, yawning, malaise, tiredness, and disease of head, heaviness in head, heaviness in the eye, indigestion, and laziness are caused when the person suppresses the desire of sleep. These symptoms can be treated with the body massage and restful peace. Acharya mentioned Nidra as an indicator of health. Acharya mentioned that Sukh Sopna means sound sleep is one of the traits and sign of well health. Acharya mentioned that untimely sleep, excessive sleep, and prolonged less sleep lead to deprivation of happiness and longevity of the individual. The sleep is taken properly in terms of quality and quantity. Times brings happiness and longevity in living beings. Acharya also mentioned Nidra as a treatment of Kashreya. Kashreya means the weakness and the emaciation. Acharya mentioned that Nidra, regular and adequate sleep, is beneficial for the people having the lean weight. So sleep is regarded as a key component of treatment plans. We all know that we can know most of us in a clinic do not take the history about the sleep of a people, and it is essential. If one can take the history and give the proper advice about the sleep, we can control and prevent many diseases and treat many diseases as well. What the Ayurveda describe about the duration of sleep? By the words, Acharya Chara, Yada Tumansi Klante Karmatmana Kilmanvita, Vishebhyo Nirvantante Tada Sopati Manva. Acharya mentioned that the person fall asleep when there is a body, mind, sensory and motor organs become inactive and they detach from their objects. It means when the object of perceptions do not perceived by the sensory and the motor organs, and this sensory and motor organ do not receive the signals from the mind, then the sleep occurs, as per Ayurveda. Same, Ayurveda also describe about the dreaming. Dreaming is just a stage of mind when the sensory and the motor organ disconnected to their objects. It means that the subject of perception do not be uh, perceived by the senses, but the mind having the having its function and receive the perception from the senses, but the senses do not receive perception from the object. Then the dreaming occurs. The person goes in the various form of dream experience. The stages of sleep. They are the two stages described by Ayurveda, Swapnavastha and Sushuptavastha. Swapnavastha, depending upon what we did and saw during the Jagrita Avastha, matlab when we wake, what we see and saw. The person feels different feeling during this stage of sleep. At this stage, the individual is aware of the interior objects, but not outer objects through senses. It means the mind is active, but the senses are not inactive in the dream stage. Just like the REM and non-REM sleep described by the modern physiologist. Sushupta was the deep sleep phase. When the person is not experience anything, this is called the sleep phase. It means the mind is inactive and the senses also inactive. Then the person become in a deep sleep phase, just like non-REM sleep. Only the essential process that keeps life alive, such as breathing and circulation, occurs in the deep sleep phase. That the deep sleep stage where the person is not dreaming and desiring for anything. There are the three stages of life: Jagritavastha waking phase, Sushuptavastha deep sleep phase, and the Swapnavastha dream phase. In the Jagritavastha, we show that the mind is active and the senses organ also is active. Both receive their object of perception. In a Swapnavastha, mind is active, it receives its perceptions, but the sense organ inactive. That they do not receive their perceptions. In the deep sleep phase, both are inactive. Now, what the Ayurveda tell about the physiological effect of Nidra? Ayurveda tell by the words Nidrayatam, Sukham Dukham, Pushti Kashyam, Balam Abalam, Vishta Klivta, Jnanam Agyanam, Jivitam Nacha. I will explain each and every verse individually. Sukh and Dukh. As we all know, Sukh and Dukh both are the lakshan of Atma, the consciousness. They both are the feelings. Acharya mentioned that the Sukh felt during the Arogya, means the healthy state of life, and Dukh felt during the Vyadhi, when the person is diseased state. So, Samyak Nidra, in terms of quality and quantity, lead to happiness and cheerfulness. On the opposite side, Asamyak Nidra, less sleep, excessive sleep, day sleep, and night awakening, lead to sorrow, lead to dukha. So, sleep having an effect of the emotional system and the mental faculty. Pushti and Kashariya. Pushti, Kashariya both are the represent the growth and development of the human body. Pushti means healthy body weight. Kashariya means lean and emaciation. Acharya described that the person having the normal and moderate sleep, having the moderate physics, neither emaciated and nor overweight, not obese. So sleep having an effect on the metabolism of the body and each and every cell of the body, and digestion at the level of cell, tissue, and the organ system. On the same side, excessive sleepiness leads to overweight and obesity as per the Ayurveda. Bal and Abal. Bal means the represent two states, Sharik Bal and Mansik Bal. Sharik Bal represents the strength of all the physiological system, and Mansik Bal represents the function capability of mind. Abal means when the person not having the adequate physical and mental strength. So Acharya Shushruta mentioned that the person having normal sleep contains the adequate bala. So Nidra in a proper quality and quantity lead to the muscular strength and the maintenance of the sharik and the mansic strength of the body. Vrishta and Kalivta. Vrishta is the healthy reproductive health and Kalivta represent the unhealthy state of reproductive system. Acharya mentioned that the person having the normal sleep contains the healthy reproductive life and capable to perform sexual activity. So sleep influence the reproductive system as well. There are so much articles in the PubMed which show that the inadequate sleep and sleep deprivation lead to infertility, less sperm count, low sperm quality as well. Gyan Agyan. Gyan is the knowledge, and Agyan is the false knowledge. Samyak Nidra helps to promote the knowledge, and Asamyak Nidra leads to obstruction of knowledge. So sleep promote the higher intellectual faculty like learning, memory, spatial senses, and the motor function as well. Jivitam or Jivitam. Sleep having the restorative and rejuvenating function, sustaining the life. Acharya mentioned that the person having the moderate and normal sleep live 100 years. It shows the importance of sleep in life. Through its influence on the every physiological system, sleep play important part in maintenance of life. So life of every cell, tissue, organ, and organ system depend upon the sleep. And one more system which depend upon sleep is Varna. Varna is a skin complexion. About the skin health, Acharya mentioned that the person having normal sleep having the good skin complexion. So sleep influence the physiology of skin and its appendix. There's need of study for topic of research to analyze the effect of sleep on the skin complexion. By this figure, I just tried to show how the sleep influence the various physiological systems. Pushti Kashriya impact the digestive system and the metabolic system. Sukh Dukh the mental faculty and emotional system. Varn the physiology of skin. Jnana Jnanam, sensory and the motor faculty, higher intellectual faculty, Vishta Kaliv, the reproductive system, Balabalam about the immune system, muscular system, cardiovascular system, and respiratory system. Which show that the Ayurveda, thousands years back, also describe the importance of sleep and its impact on the various physiological system as well. Time and duration of sleep. Acharya mentioned that the night is the best time of sleep. And Acharya also mentioned the impact of Ratri Jagaran and Diva Sopran. Ratri Jagaran means night awakening. When the person stay awake during the night, it creates roughness in the body. It creates the uh, enhancement of Vata disorder as per Ayurveda. And Diva Sopran, daytime sleep. Because unconsciousness means the snigdha and the sleeping in the sitting position when we're taking nap, like in modern times, result in the neither restness and unconsciousness. It means if we sleep in the sitting position, taking a nap, it is good for health. But if we're taking Ratri Jagara and Diva Sopan, it is not good for health. The statement mentioned that the sleep should be taken at night and should be in relaxing state. Acharya also said that clearly that the night is a natural time to sleep. And that bed and one should sleep adequately at night in accordance with the one's nature. Ayurveda also tell about the sleep hygiene. Acharya mentioned that the application of oil on the head lead to sleep. So one should apply oil on head before go to bed. Acharya also mentioned the snan, bathing induce the sleep. So one should take bath before go to bed. Acharya also mentioned the padabhyam, massaging on the foot, induce sleep also. Intake of buffalo milk is a sleep inducer as per Ayurveda. Presence of comfortable and soft bed, listening music, sound which give pleasure, apply the scent and perfumes which gives pleasure. Also useful for as a dietary and a lifestyle changing for maintaining the sleep and for the sleep hygiene. Now we talk about the Diva Swapna. Acharya also had a concept of Diva Swapna, daytime sleep. Sleeping at daytime is considered as Diva Swapna. आचार्य mentioned that अगर आप रात को नहीं सोते हैं, मतलब अगर आप रात को 8 घंटे नहीं सोते हैं, तो दिन में उसका हाफ घंटे आपको सोना चाहिए. मतलब आप 8 घंटे नहीं सोते तो आपको 4 घंटे दिन में सोना एसेंशियल है हेल्दी लाइफ के लिए. इट इज द मेंशन क्लियरली इन आयुर्वेदा. They are the some of the indication mentioned in Ayurveda for Diva Swapna. If there is summer season, person may sleep at daytime. It is good for health. If the person is suffering from the disease like indigestion, breathlessness, hiccup, thirst, diarrhea, insanity, he can sleep at daytime as per Ayurveda. If the it's old person, children, if the person is acclimatized to the day sleep and the person is weak, he can sleep at daytime. Special activity, which also as an indicator of daytime sleep, is excessive singing, with the person is so much singing, doing so much work, so much walking, excessive indulgence in sexual activity, carrying heavy weight, taking long journey, it suffer from anger, sorrow, and fear. He can sleep at daytime. What are the harmful effects of daytime sleep? They are some of the effects: respiratory diseases, cardiovascular diseases, memory impairment, impairment of intelligence, giddiness, drowsiness, decreased productivity, headache, heaviness in mind, malaise, loss of digestive power, swelling, and loss of appetite. All of these are the harmful effects of daytime sleep. We all know most of the females nowadays, as a housewife, sleep at daytime. It is not good for their health. It is lead to so many diseases in a long term. So one should sleep according to his health, according to his prakriti as per Ayurveda. Whether it is an indication for daytime sleep, then the person will sleep at daytime. If it not, you should avoid daytime sleep. One should avoid. Ayurveda also describes the analysis of Nidra by the three. Ayurveda describes three types of prakriti, the individual, Vata individual, Pitta and Shleshma. Vata individual having the lean body mass, Pitta having the moderate, and Shleshma having the uh, toward the higher side of body weight. So Vata Prakriti individual taking light sleep, it is good for their health. Less than 6 hours sleep, as Viva ma'am said that about the short sleepers. Naturally, short sleeper are the Vata Prakriti type person. Pitta Prakriti are normal, moderate sleep, 6 to 8 hours sleep. Sessional Prakriti deep, more than 8 hours sleep. Just like the long sleepers, we having naturally long-term sleep. It is what the Ayurveda tell about the sleep, its generation, its analysis, its harmful effect in a daytime, its beneficial effect on the various physiological system. Thank you. Hello. Thank you, sir.
Yeah. Thanks, Dr. Ankur, for sharing your take on what Ayurveda think about sleep medicine, and what are the various acharyas in Ayurveda, and what are their opinion about the sleep and all. Anybody from audience want to ask question from Dr. Ankur? They can ask question by unmuting their microphone. There is no any questions, and we are lagging a bit, so 10, 15 minutes. So we are, with your permission, Dr. Ankur, we are moving to our next, speaker.
Yes, sir. Yes, sir.
Should we
Thank
move?
you, sir.
Yeah, yeah.
Yes,
So
sir.
nice of you for spending your time, Dr. Ankur, joining from All India Institute of Ayurveda, New Delhi. Thanks for
Thank you.
joining us in interactive meeting.
Okay.
Now we are going with our next speaker. Next speaker is Dr. Anup Kumar Dhanvijay. Dr. Anup, are you there? Can you unmute your microphone, and can you open your
Am I audible to you, Dr. Nurul?
Yeah, you're audible.
Okay, okay.
Yes. And you are not able to see your camera is off actually. Can you switch on your camera? Okay.
So I'm sharing my screen.
Yes. By the time you share your screen, let me introduce you.
Is it visible to everyone?
Yeah, it's visible. It's visible, but it's not in slides here. Once you make it, you can do this if possible.
Is it now?
Yes, yeah. Now it's
Okay. Good morning to everyone.
So let me
Is it morning
introduce
or it is
Dr.
afternoon?
Anup, and then whatever I would be letting, you can get the opportunity to reintroduce yourself. Let me introduce you as a commentary for our speakers. So Dr. Anup Kumar Dhanvijay, he is MD Physiology, and he did MD from GS Medical College from Delhi Hospital, Mumbai. He is total of say 12 years of experience. He served in many medical colleges and all. Right now, he is as associate professor in Department of Physiology, AIMS, Waiver, but he already worked in Rama Medical College, Kanpur, then RMI Medical College, Bareilly, then he was assistant professor at PCMS, RC, Bhopal. And he has been, regular speaker on multiple series, most especially sleep medicine, and his research focuses sleep physiology and technology, autonomic function test. And he has already published 21 papers in national and international journals. Topic is sleep, yoga, meditation, cardiovascular health. So over to you, Dr. Kumar, for if I'm left anything, you can add on and we'll start your conversation. Thank you.
Yeah, just okay. Thank you, Dr. Nurul. Thank you for your introduction. I'm Dr. Anup Kumar. I'm currently working in AIMS Devgar as associate professor in Department of Physiology. So my special interests are sleep physiology. During the last, I think, 8 or 9 years, I have published 4 studies related to sleep or sleep restriction, either sleep restrictions or related to sleep. Currently, I am working on a article which is related to the predictors of OSA in the or gender differences of OSA and females. Hello.
Yeah, you are visible, Dr. Anup.
Okay.
But your slide is again not in a slide representation.
बाद में करता हूँ.
अच्छा,
ठीक है. Okay. So basically, as a physiologist, what I have learned that physiologists can have very important roles in doing the polysomnography. Means they can play important role in doing sleep studies. Ultimately, the clinical part will be can be dealt by the respiratory medicine people or dentistry people or psychiatry people and other branches. But as far as the sleep studies are concerned, we can play an important role as a physiologist. So today I am talking in terms of that. I will be talking. So basically, OSA is the most common form of sleep disorder breathing, and it is characterized by repetitive episodes of complete or partial obstruction of the upper airway during the sleep, leading to interruptions in breathing. So ultimately, these interruptions ultimately leads to a sleep problem, and in long term can lead to many NCDs like hypertension. One special type of hypertension, that is resistant hypertension, is seen in this group of people, especially those who are having severe form of OSA. So OSA are basically two types. It can be central or it can be obstructive, or it can be like both mixed. But obstructive sleep apnea is most common. As such, the sleep apnea syndrome is common in India, but it is not reported properly. Means the number of patients which are getting going into sleep studies or polysomnography and ultimately being given the treatment is the percent is very less. So there is a lot of scope in this field, especially because the signs and symptoms in females are somewhat different, and the severity is also different as compared to males. The number of females turning up for the sleep studies are very less, but it doesn't mean that they don't have that problem. Only thing is that we need to look after the specific symptoms which are present in the females, which are different from that in males. So now, what are the common symptoms of sleep apnea? Now, obviously, in males, the loud snoring, it's also present in females, but as compared to females, this phenomena is more common in males. There is excessive daytime sleepiness, which is also common in males, but morning headaches and mood swings, this or irritability or insomnia, these are more common in females. So ultimately, not every patient that is coming to you or respiratory medicine people will have all the symptoms, but the symptoms will vary according to the patient. Means in females, the patient may be obscured, or female may not go to the doctors because their severity is less, or maybe the symptoms are not the typical one. So they can be counseled, means because of which they will see a doctor. So this group of population should be looked after. It's a need of the study, need of the hour. Now, what are the diseases which are related to OSA? Means long-term OSA can result into it has increased risk of hypertension, heart disease, stroke, type 2 diabetes, and accident due to daytime drowsiness. It can also be important for it can have impact on cognitive function. Means in a long term it can lead to cognitive decline, and ultimately there can be uh, effect on your quality of your life because of all these things. For example, there is insomnia, or there can be drowsiness during the daytime, so the work efficiency of the person can also decrease. So ultimately, what is the gold standard for classifying the patients whether they have central sleep apnea or obstructive sleep apnea? The polysomnography is supposed to be the gold standard. So basically, as physiologist, I'm more interested in reporting the sleep stages of the sleep and identifying the patients, those who are having sleep apnea, means obstructive sleep apnea. So I will just go through what is done basically in when you are doing polysomnography. Now, the polysomnography can be one for as a part of treatment, or the second can be diagnostic. Now, physiologists as such can have role in diagnostic polysomnography rather than the treatment part or treatment polysomnography. So the most commonly done polysomnography or the sleep study is called as type 1 sleep study, in which following parameters, that is electroencephalogram, electrooculogram, chin EMG, that is electromyography, airflow, that is nasal airflow, then respiratory effort and O2 saturation of the subjects are seen. Apart from that, we can also record the ECG of the patients. If the patients can have some problem related to heart, because of as I have discussed that OSA can result into heart diseases. Long-term OSA, obstructive sleep apnea, can result into heart disease. So there can be some reason for the patients to develop these diseases. So ultimately, we also record ECG during the sleep studies. But these 7 parameters are generally done in diagnostic sleep study, which is done in a sleep lab. And ultimately it is attended sleep study, means it's a overnight polysomnography which is done, and then in the morning the physician, the reporting physician will study the sleep recording of the night, and ultimately he will report about whether the patient is suffering from the levels of obstructive apnea. It can be mild, moderate, or severe, depending on the severity of the obstructive sleep apnea, or whether it's central sleep apnea, or both a mixed type. Then ultimately he will refer the patient to the respective departments for the treatment. Now, this is 1020 system, which is used in reporting or doing the EEG studies. Now, the same EEG 1020 system, montage system, is followed when we are doing polysomnography. So EEG being the most important part, because EEG is useful in categorizing the stages of the sleep, and ultimately because certain part of the sleep have more tendency to develop OSA, means for example obstructive sleep apnea resulting into either in apneas or into hypopneas will be more common in REM sleep, because the tone of the muscles decreases during REM sleep physiologically. Ultimately, what happens during REM sleep, there is more chances that the patient will develop apnea because of obstruction due to laxity of the muscles, which are ultimately blocking your airway. So EEG is a very important part of polysomnography study, as I have already mentioned. So normally in EEG we use many montages, but in actual EEG we don't place so many electrodes on the patient's head. Mainly the frontal and central, parietal, and occipital. These, and ultimately M1 and M2, which are used as reference electrodes. and the Nasian and anion electrodes are placed. And the combination of this electrodes ultimately is recorded as a potential difference between the two electrodes which are placed, and ultimately that potential difference ultimately will cause the fluctuation or the of the signal. Ultimately, if there is a negative deposition, means negative value is there, then there is positive deflection, and vice versa. So ultimately, EEG is used for reporting the 5 stages of the sleep, which is commonly seen in adult person, which is wake stage, N1 stage, N2, N3, which are part of non-REM sleep. Now, basically, originally NK classification was given by 2 scientists, which was used previously, especially in physiology. This classification is still used. Accordingly, that non-REM sleep is divided into 4 stages, but clinically, nowadays we all follow ASM, American Academy of Sleep Medicine guidelines are followed for sleep scoring. According to that, they have categorized the sleep scoring according to age. Means for adult it is from 18 years. For children it is from 2 months to 18 years, and for infant it is below 2 months. So accordingly, they have different stages of sleep. But because OSA is more common in adults, and generally in females it is after the menopause. So the stages being the wake stage, N1 stage, N2 stage, N3 stage, which are part of non-REM sleep, and ultimately REM sleep, which is a rapid eye movement sleep. So ultimately, because there is a loss of tone during the non-REM sleep, so we will see the apneas and hypopneas in these stages of sleep, and ultimately we will report those hypopnea and apnea events to calculate a apnea index. Now, last time means previous year we conducted a workshop in our institute in Ismcon, in which Department of Physiology along with Department of Respiratory Medicine, we gave a hand-on workshop, or actually gave the training, or how actually it is done, how the placement of electrodes is done. So this person ultimately is just for he was doing the demo from the Philips Respironic company. These people come, and ultimately we give the demo of how the electrode placing is done. So it's showing the one electrode is placed on his chin. Basically, it is for recording the chin EMG. Then there is one record. This electrode is there, and another electrode adjacent to, means on the opposite side above the eye is placed, and ultimately these 2 electrodes are there for measuring the activity of the EMG or electrooculogram. Means the movements of eyeballs are recorded. Ultimately, the movements are more important when there is REM sleep, and ultimately we recognize the REM sleep because of there is movement in the eyeballs, and there is certain record that is recorded in the sleep stages or during the REM stage for identification. Then this is Nasian, and opposite is Anion. This is parietal, and rest of the electrodes we haven't kept, means because it was just for demo purpose. So as a whole, this was the placement. So this is the Nasian, and these are they have also kept reference electrodes, and these are parietal. And this is the software or hardware of the Respironic company, to which they will attach. There is again a belt that is attached. This belt is basically for recording the movements of the patient when he is actually sleeping. So ultimately, movements or respiratory movements, and ultimately there is this cannula, which is nasal cannula, and this cannula is used for knowing the airflow, and ultimately this airflow ultimately will tell us whether there is apnea, hypopnea, or there is obstruction during the obstructive apnea. Ultimately will be recorded in our record of polysomnography, and ultimately the diagnosis can be reached depending on this whether we are able to see those movements. whether there is increase or decrease airflow, especially decrease airflow in obstructive sleep apnea. And ultimately this is attached to the computer, which is in which they have already uploaded their software. And then there is this, they will tell us whether they what electrodes we have actually attached to the respective areas of the skull. And this is the actual record in which we see the parameters as I have already described. So basically EEG, this is the EEG. There was some problem in that movement from the person. So there is some artifact is showing in this. Then there is EEG record is there. This one is EEG. Then there is thoracic and abdominal movement. Then this graph shows the SpO2, that is oxygen saturation. This red one is oxygen saturation. Then it also tells us about whether there is body is in upright position or it is lateral, right lateral or left lateral. Then also it shows the flow of the airflow, which is through that nasal cannula we have placed. So all these parameters ultimately, as per the ASM guidelines, these all the parameters are minimum to report the standard diagnostic sleep study, which is done in the sleep lab. Now there are also other types of sleep studies like type 2, type 3, type 4, type 5. Type 5 is mainly PAT, and type 3, type 2, type 3, and type 4. They are unattended. Means sleep technician may not be required in these studies, and it can be done it can be done either in the lab, or it can be done in the means portable PHG machine can be used for those kind of studies. And ultimately, as you go from stage of means type 1 sleep studies to type 4, the number of parameters which are ultimately required to be studied decreases. And now this is the actual recording. Means when I was doing this ASM course, so these are the actual recording. If we log into the ASM website and we register for their course, then there are records of EEG or sleep studies is available there. And from these sleep studies, as we can see, these two lines, or this one and two record shows us the eyeball movements. Then 1, 2, 3, they are respective EEG records from frontal, central area, and occipital area. And ultimately these three records are enough, which is normally more in cases of when you are doing EEG reporting, are enough to tell the stages of sleep. And ultimately, depending on the whether it's the combination of these two can be used for knowing whether what stage of sleep the patient is in, whether he is in wake stage, or he is in rapid eye movement stage, or whether the patient is in non-rapid eye movement stage. So there are certain criteria or certain diagnostic features of these waves ultimately which we use to label it as what stage it is. For example, the K complex which are seen in N2 stage of the non-REM sleep. So and at the same time there is no contradictory movement of this this eyeball movements are not seen in this. So ultimately we will label this this is definitely not REM. So this is most probably N2 stage. Means how this is how we learn how to report the sleep staging. And then there is a chin movement, chin EMG. This graph is showing the chin EMG, which is not showing excessive movement. Then there is EEG record. So EEG record is basically done to know whether this is bradycardia or some kind of arrhythmia is there, tachycardia is there, supraventricular tachycardia, and all these things. Then there are certain electrodes which are placed on this right and left leg, which are basically used for body movement or leg movement. There are certain diseases in which patient have these movements of their legs. So this record is taken to know what is the whether there is movement in the limbs. And periodic limb movements, for example, is one of the conditions which is seen in certain patients. So certain sleep movement, to diagnose certain sleep movements, this right leg and left leg recording is done. Then there is this snoring record, especially in obstructive sleep apnea patients. There is snoring is seen, and ultimately followed by the apnea episode will be seen, or hypopnea episode will be seen. Uh, um, because there is obstruction, so the patient will go into snoring, and when he will like wake up from his this sleep, because of that, and sleep fragmentation will occur. Then ultimately again the hypopnea will not occur, and for some time again you will get the normalcy this pattern of this waves, uh, uh, and ultimately we can report hypopnea or apnea index, and accordingly the severity of OSA can be judged. The last one, this is SA2. This is saturation of oxygen, or O2, partial pressure of O2, and this ultimately it decreases in cases of obstructive sleep apnea, and this is ultimately one of the ASSM guidelines, or ASM scoring includes this as a very important parameter for knowing whether patient has sleep apnea or not, obstructive sleep apnea is there or not. So this one looks normal. Ultimately, when it goes, there are certain set of guidelines from ASM for what should be the actual decrease, or how should be the decrease in these waves or the records to label whether the patient has obstructive sleep apnea or central sleep apnea or other type of apnea. Now, as we can see that uh, these waves, ultimately what we learn in physiology, this is a alpha rhythm. So at the same time there is movement of legs of the patient. So ultimately we will when we are reporting this, this is called one epoch, which is of 30 seconds, and this in which there are like as we can see, the stage is N1 stage, and there are no respiratory movements, and there is limb movement is not there. So limb movement has started again, because of why we are not labeling it as limb movement. Again, there are certain set of guidelines for that. Now coming to the gender differences of OSA presentation and risk factors. Now we had done one study. Now there have been many studies done all over the world, but there is paucity of data, especially for India. So we had done one study in which we studied the what are the specifics of presentation in males and females, and what are the risk factors which are seen in this if you look for the gender differences of the males and females. So these were the findings. Ultimately what we have seen that also the results go well with what other authors have done. This study is not published yet. We haven't published the data yet, but still I am giving the findings for my topic. So the prevalence of OSA, we have seen that those females who have more like crossed the menopause stage of their life, they have more tendency to develop OSA. So there may be some hormonal influence on the condition. And as compared to men, which have this typical symptoms such as loud snoring and observed apnea, means when they are sleeping, their spouse can observe that they are developing apneas, and ultimately they have, because of sleep fragmentation, they have this excessive daytime sleepiness. But in females, we seen that they have certain symptoms. That is, they were coming more with insomnia, morning headaches, fatigue, mood disturbances. Similarly, if you look for the certain diseases in this population, so what we observed that females, those females we were presenting with OSA, as such the percentage of females who reported to the sleep lab, for which a diagnostic sleep study was ordered or prescribed by the respiratory medicine people. It was seen that the percentage of females reporting to the sleep lab or percent, it was only 33%, as compared to males, which was around 67%. And they didn't have this typical symptoms like excessive D-type sleepiness, and also the OSA tendency, means severity of OSA was less as compared to males. But yes, they were not reporting well, and ultimately there was need to look for this problem, because female, because of their uncommon symptoms, for example, insomnia, morning headaches, and fatigue and mood disturbances. Apart from that, many females, those who were like reporting has problem of hypothyroidism. Now we need to go into detail why such things happen in females. Like some females who have thyroid disorders are more have tendency to suffer from OSA. So research needs to be done in this. Now, the women have smaller areas as compared to males, but the hormonal imbalance such as estrogen can affect the upper one. So that is the reason why females will have more tendency to develop OSA after the menopause. Now, though the OSA untreated in men and women, they have certain risk factors. OSA is more common, means they will have cardiovascular disease, hypertension, stroke, diabetes, depression. But it was seen that hypertension was more common in females as compared to males. When it comes to OSA, means severity of OSA ultimately was correlated with hypertension. Means if females have like severity or more severe, that is severe obstructive sleep apnea, then it was found that generally it was correlated with hypertension as compared to males, which had different diseases like cardiovascular diseases or diabetes, as that may be. Now, it was also seen that in males as compared to females, the obesity, which was ultimately the obesity was the cause for males as well as females. But in males, the symptoms was more severe at a lower BMI. Means and ultimately in females it was found that as their BMI increases, then there is a chance that the severity of their and especially after menopause, the chance of getting into OSA, obstructive sleep apnea, was increased. Still, the polysomnography remains the gold standard. Now, the last but not the least, we found that the BMI is the most important predictor in females who are morbidly obese. As this was actually our study finding, as the BMI in females increases, the chances of getting the more severity of OSA and reporting in the females, the female being reporting that OSA into respiratory medicine clinic or any other clinic increases. So that was from me. Thank you. Dr. Nurul, over to you.
Thanks, Dr. Anup Kumar, for sharing your, thought on, various sleep-related issues for female. Actually, we just had on last week we have in the Women's International Day. Actually, so it's a very nice that you thrown light on the sleep apnea related to women. Any audience would like to ask question from Dr. Anup Kumar?
Dr. Nurul, Dr. Sonal Yerpude here.
Yeah.
If with your permission, can I ask a question? I'm a dentist.
Yeah, Dr. Sonal, yeah, go ahead.
Doctor, I'm a dentist and I have been dealing with sleep apnea study and all that since past 5 to 6 years. And what we generally give is a mandibular advancement device that was already prescribed. So as a dentist, if I have to prescribe a PhD study, and how a dentist will play a role in this whole pattern other than just giving a mandibular advancement devices, because they are working, because I've had patients who have had the triple UP surgeries all done, and still they had the sleep apnea disorders which were benefited with mandibular advancement devices. So but then as a dentist, when I'm prescribing a PhD study, so what is the criteria? Like, suppose the study will be read by somebody, because we become a third party in this whole picture. We are the providers for some treatment plan. So when the patients walk into our practice, like, as a guideline for a dentist, what will it be? Like, if you have to tell a dentist that how to start identifying the patient is one thing, and how to plan these prescriptions or plan the desired PhD study, and how to go about giving the right candidate selection for that appliance.
Ma'am, generally it is what is done is if it it depends on the severity, and what is done that it's a team effort. Means in our institute is like we are going to start our sleep lab soon. What is that? There is a team of physicians. Means from every department they have taken one person as a team member, and ultimately all these team members ultimately come together for certain patient, and depending on what is the problem in that patient, means what can be corrected in that patient, then the patient is given the is referred to that respective this domain. Means for example, if there is something which is related to respiratory medicine which can be corrected from the respiratory medicine people, then they will deal with it or there is some problem like a psychiatric problem or related to dentistry, then the team. So it's always team effort rather than a single department looking after the treatment of the patient. So I think my opinion is that like when the PhD study has been done, depending on the severity, then the patient can be referred to the respective domain, depending on what might be the ultimately what most of the patient requires positive pressure ventilation. So and generally that is given by the respiratory medicine people. So accordingly you can like take opinion from that department, and you can go forward with your decision. It will be better if you concern ask the other departments who are working with you, or refer that patient to that respective domain accordingly. Because
Okay,
I
thank
am
you.
actually
Thank you.
mainly concerned with like doing the PhD studies rather than deciding the course that is required for that person. Ultimately, treatment part. We are as a physiology people, we are more concerned about diagnosing the condition rather than deciding the treatment part, which is generally done by respiratory medicine people.
Okay, thank you so much, doctor.
Yeah.
Any more questions from audience?
Yes, I would like to ask a question.
Hanji, Badar Saab boliye.
Yeah, Dr. Badar. Continue.
Yeah, what is the role of BiPAP in the treatment of OSA?
BiPAP in certain patients they are like they will not like OSA का कुछ like आप when you are giving normal treatment, ठीक है, positive pressure ventilation, then they may not be good with that. Means what they are not giving a good result, or they are not able to like use that positive pressure ventilation. Then we have to like other choices like BiPAP ventilation. You will go for these devices which are more advanced as compared to means generally what is used normally.
Okay, okay, thank you.
It is ultimately the compliance of the patient that is one of the factor which decides whether you will go for certain treatments. Compliance is very important.
Yes, compliance is
Okay,
very
thanks,
important.
Dr.
Thank you.
Yeah, you would like, Dr. Badar, if you would like to add anything.
Okay, nothing from my side. You can continue.
Yes. Thanks, Dr. Anup Kumar, joining right away from AIMS Deoghar, Department of Physiology. With your permission, should we move to our next speaker? Dr.
Yeah, thank you,
Anup
Nurul.
Kumar?
Dr. Nurul,
Yeah.
thank you.
And if any more questions you are getting from our audience through email, they can post a question on email, ismcon on 24@gmail.com. They can send their question to us and we'll forward it to Dr. Anup Kumar for your answer of the query. So you can, ask the questions if you are not getting the questions right away here. So Dr. Thanks, Dr. Anup. We are moving to our next speaker. Our next speaker is Dr. Amita Nene, but due to some, his a personal reason, she could not join. Dr. Amita Nene is a head department of respiratory medicine, Bombay Hospital. So she couldn't make and she's not available now. And we are fortunate that the next speaker, Dr. Manjari Tripathi, her scheduled talk is from 1 p.m. But I think she is there in the Zoom room. So with her permission, we can, start her presentation.
Yes, is my presentation seen?
Just hold on.
Are you able to see my presentation?
Yeah, your presentation
Okay,
is
okay.
visible. Your slides
And,
are visible, but it's not in slide share mode. Could you?
Yeah, that's what
repeat
I'm
it?
trying to do. Where do I go for the slide share?
You can press Control F5, or in the
Control.
bottom. In the bottom there are, the icons are there. Three icons.
Bottom, I'm not seeing it. That is the issue.
You can do one thing. You can press Control and F5 simultaneously together. Maybe
Yeah, I'm trying that. Not able to do it. I don't know why it's not showing. It's very strange. Normally it does show up here.
On the bottom there is an option of the percentage. No, the 55% is written, and then you come to the left side of that. Further left, there is an option for there are 3-4 icons. No, there is a notes are written in the bottom, and then 55%. You go slightly, yeah, come or left. Yeah, there are 3 icons. No. Come further left to yes. Left.
I don't know where.
Yeah. On the left there is a the computer sort of icon is there. You can just click that. It will go to the screen share mode.
Left computer. This one?
No. On the bottom.
Okay.
On the bottom there is a notes are there. On the right side of the notes there are 4. On the 55%. No, go to the left side. There is a 4 icons. Left. You are going to the right actually.
Actually, this panel is obstructing my vision.
Okay. You do one thing. You just open and make it a slide share mode, and then do the slide share. You go out of slide share. Yeah. Open the slide, make it a slide share mode, and then share your slide.
Now I can see the slide share. But then I need to escape.
No. You just go to this slide share screen on a green phone.
Are you able to see my slides now?
No, it's not visible now. It's not being shared actually. You
Very
share
strange.
again.
This has never happened to me before. I have been presenting in and out, but
No, it's sometimes that it happens. It's a usual actually.
Still I am not able to do it.
Yes, it is visible, and either you can increase the the 55%. No, you can increase the you can increase it to say maybe I don't know, 60%.
No,
yes.
that doesn't help at all. No, it doesn't help. I'm not able to share.
Make it 100% if possible. There would be visibility increases.
No, it won't. It has to be slide share mode. I don't know why it's not happening. It's very strange. Never it's happened to me before. Is there something wrong with the whole thing?
So can we move to the?
I don't know.
Can we move to the next slide? Let's see what is the font and if it is visible to the audience, then we can.
No, because I have hidden slides, so it doesn't
Okay.
work. I don't know why it's not showing. Is there anybody in your audiovisual team who could help out?
You can do one thing. You can send this email to us, and
I've got videos on it, so I don't think I can send it at all. Is there anybody else who can help me with You have anybody?
You do one thing, Dr. Manjari, leave the Zoom meeting and come again. Maybe it will work.
May I suggest something?
Yeah, please tell.
You can mail your power presentation to Mr. Nurul, so he can.
Yeah, that's what I'm saying. The PowerPoint is huge. It has videos in it also.
No, Dr. Manjari, you do one thing. You just leave the Zoom and then come again. Maybe.
Yeah,
it will
I'll
work.
try to do that.
Yeah, please.
Hmm. So I'm trying again. In case it doesn't, then I'll just excuse myself because I've never faced this issue before. And this is the first time that this kind of thing is happening to me. So let me try.
Yeah, please.
I've lost my PowerPoint also now. It's somewhere in the computer because all these files are so heavy. I thought it's going to be easy, but it seems to be more difficult.
You take time. Not to worry.
I'm
Yeah,
trying to
it
do that.
happens actually. Yeah, the technical features are happening in the virtual presentation. So there are the pros and cons of this format.
Mhm. My PowerPoint is not opening now. That is the problem. What was opening before is just not responding. I think I'll have to excuse myself. Very, very strange. Hello.
Dr. Manjari. You are not able to, locate your PowerPoint presentation in your device.
Yeah, so I can now open it. Thankfully, the PowerPoint has opened.
And try to share the screen. If it is not coming on that presentation mode, no, you can continue with that only. Not to worry.
Is it okay now?
Yes, yeah, it's okay.
Okay. So now it seems to be in the presentation mode.
Yes, yes.
So
yes.
sorry for the delay and the technical glitch.
Should I briefly introduce you and then you can continue with
So
your presentation?
I'll introduce myself. I'm Professor and Head of Department
Okay.
of Neurology
Okay,
at
thank
AIIMS
you.
Delhi. And my areas of interest are epilepsy and sleep and cognitive disorders. I run a sleep lab with trained technicians at the AIIMS, and we are investigating most high-risk neurology patients who have sleep disorders, particularly strokes with obstructive sleep apnea or parasomnias and epilepsy differential. So my topic is sleep and epilepsy, and I'll try to finish it in my allotted time. So basically, the relationship between sleep and epilepsy is a bidirectional relationship. Sleep has an effect on seizures, and seizures have an effect on sleep. And there is an intricate relationship between the physiology and the pathology of both. The association is not new. It has been stated from the times of Aristotle and Hippocrates. And it was Goers who discovered that 1/5 of the grand mal seizures occur in sleep. And there are two peaks of seizures in sleep. One is immediately 2 hours after sleeping, and the other is about just before awakening at around 3 to 5 a.m. and then after awakening. So basically, in 1929, this relationship between sleep and epilepsy was, further ratified by various other scientists like Langdon and Down, and Brain and Patry. And then from then on, there have been several investigations as to why they occur together, and what, if they occur together, how can they confound a sleep, a sleep doctor or a sleep physician. So Gibbs and Gibbs then found that there are certain interictal discharges which worsen in sleep. And Niedermeyer described activating influence of arousal on epilepsy. So this is a very nice chart which has been, drawn by an avid researcher from Australia, Derry, where you can see that there are stimuli during sleep, and these stimuli could be physiological or pathological. And the physiological stimuli during sleep, of course, we know are snoring, cough, sniffling, or some external noise which comes, maybe it's like the crow or the morning sounds like a temple bell or whatever. So basically, those could be physiological sounds or pathological sounds or pathological stimuli, which are the seizures. So they will cause a non-specific arousal behavior. The physiological stimulus also will cause, the eyes opening and some eye and head elevation, staring around. Whereas a pathological stimulus like aberrant neuronal discharge can result in a clinical seizure, but can also result in parasomnia and also can result in just an arousal and then return to sleep. So what are the challenges? As a sleep physician, one should understand that the phenomenology is occurring in sleep. So there is nobody to give you history unless some caregiver is wide awake in the night. And most often the patients do not have memory of what happened in sleep. So nocturnal events may not be observed properly, and bed partners may not be present and may not be very fully awake or coherent. There's another talk by Dr. Sapna on parasomnia, so I'll not be talking about that. The basic thing is the patient will present to us, the sleep physician, with abnormal movements in sleep. So we have to figure out whether these abnormal movements are parasomnias or seizures or just a normal physiological arousal. Now, most important for differentiating is, of course, a caregiver or an eyewitness's account. But the eyewitness is not always available. So here in these circumstances, a home video account or a CCTV account, we have caught many parasomnias and seizures due to CCTV deployed in patients who are having frequent events. So a home video or a CCTV, which gives us a situational video, helps us quite a lot. And since these parasomnias or seizures are predictable, as I told you, occurring 2 hours after sleep or at 3 to 5 a.m. or just after awakening, it is possible to time your CCTV so that you pick up those events. So obviously you will have to see the home videos, you will have to see the history, you will have to see the routine and sleep deprived EEGs, and you will have to do a polysomnogram in certain situations. And in certain situations, you will have to refer to an epileptologist to do the video EEG. So as I said, there are several relationships between sleep and epilepsy. And are there some epilepsies which are related to sleep? So we can see in sleep, we have two phases, the non-REM and the REM, and the non-REM is again 1, 2, 3. So what happens? Which one of these is more epileptogenic? So the non-REM sleep is a state where there is extensive neuronal synchronization. Almost all of the brain activity is highly synchronized. So this is a favorable, kind of manure for seizures because there's highly hypersynchronous activity and there's recruitment of critical neuron mass. So the non-REM sleep is the one where the seizures will occur. Whereas the REM sleep is the one which is anti-epileptogenic or prevents seizures, in which there is a highly desynchronized state. That is, the neurons are all firing on their own at different rates. And hence, Because REM is a desynchronized state, there is a decreased interhemispheric traffic and it limits the spread of seizure discharges, and so it is an anti-epileptic. Plus, the atonia during REM prevents the motor seizures. So it's very easy to remember. REM is highly desynchronized and is anti-epileptic, whereas non-REM provokes seizures. So what is the effect of sleep on epileptiform activity? So as you can see here, in sleep, there is an activation of interictal epileptic discharges. This is because there are periodic arousals and instability in patients who have seizures and sleep issues because of sleep fragmentation. And hence, you can find there are these highly volatile cycles of cyclic alternating pattern, which are responsible for an unstable sleep as well as fragmented sleep. So you can see here our lab polysomnogram where you have these, you can see the transition of the background activity. So this is what is known as CAP. And you see these cyclic alternating patterns which are there, which will, and also you see frequent arousals in the polysomnogram of these patients, which make them vulnerable to seizures. Just for the sleep physician to know, one must be aware that different seizures which occur in sleep. Commonly, it's autosomal dominant nocturnal frontal lobe epilepsy, or benign Rolandic epilepsy, or tonic seizures of Lennox-Gastaut syndrome, or CSWS, which shows continuous discharges in sleep. And this is important to know because many of us may be doing polysomnograms to rule out parasomnias. So there is a definite chronorhythmicity of sleep with seizures. And you can see here the stage 1 and 2 of sleep, which is a relatively lighter sleep compared to stage 3, is more epileptogenic, and REM is the least epileptogenic. Now, there are sleep-related epilepsies. So sleep-related epilepsies are all these which I've told you, and one should be aware of them. And just after awakening, you have seizures which are related to JME and absence. It's very important that as a sleep physician, we are aware of the FLEP scale. The FLEP scale is a scale which helps us differentiate a parasomnia from a seizure. So the FLEP scale again was devised by the group from Australia as well as from Italy. And here you can see clearly that in this FLEP scale, you differentiate it from arousal disorder and nocturnal frontal lobe epilepsy. The arousal disorder is a parasomnia. So the parasomnia usually occurs in children, whereas nocturnal frontal lobe epilepsy usually occurs in adolescents. There is a family history in nocturnal frontal lobe epilepsy, whereas in arousal disorder, the family history is higher. So there will be a family history of sleepwalking or a parasomnia or sleep terror usually. The number of attacks in seizures is 3 or more seizures, whereas in arousal disorder, it is 1 to 2 episodes only in a night. So nocturnal frontal lobe epilepsy will have more events compared to a parasomnia. And in a month also, the nocturnal frontal lobe epilepsy will have many more events as compared to parasomnia. Nocturnal frontal lobe epilepsy will stabilize with increasing age, but arousal disorders will disappear after you remove the trigger, whether it's the stress, whether it's the age, when the child grows up, it will go away. The parasomnia is usually very prolonged, more than 10 minutes, usually 30 minutes. And it's variable complexity and not stereotyped, whereas a seizure is stereotyped. And the trigger factors for arousal disorder parasomnia is a sleep deprivation, febrile illness, alcohol, stress. Whereas for a seizure disorder, it's generally without a trigger, except sleep deprivation can also be a trigger there. A patient can have a parasomnia, which is masking a obstructive sleep apnea. And a parasomnia will arise from slow wave sleep. So this FLEP scale helps us differentiate between parasomnia and seizures. So you can see this event here. And so when the history of the child was taken, we would find that she had multiple events. She used to have 11, 12 events in the night. And they were very brief. You can see it's not for 10 minutes, it's not for 30 minutes, it's very brief and very violent. So it can get confused. with a seizure or a parasomnia because of its violence. But you can see here, the EEG clearly showed polyspikes, which were frontally predominant. So this is a epilepsy. Brief events, many events, and there are epileptiform discharges, as can be seen here. Now, this can be mistaken with the arousal, the phenomenon which he's having. So the first one get confused with a sleep terror or a sleep or waking disorder, whereas here it can get confused with a arousal. So you see this girl, and here she's sitting with her mother. She's actually in sleep and she's being recorded. I hope it's playing. I don't know if it's playing or not. But basically what she has is just a stiffening on the limbs. And this is what a tonic seizure is. The tonic seizure is characterized by generalized polyspike or generalized paroxysmal fast activity. So the sleep physician must be aware of this very brief stiffening, which can look like an arousal, but it's actually a tonic seizure of a Lennox-Gastaut syndrome. Now, there was an entity in sleep disorders called nocturnal paroxysmal dystonia, which is very brief, where there's just dystonic phenomenon. And initially it was thought to be a sleep disorder, but now we know that it's not a sleep disorder, but it is a seizure phenomenon. So you can see here, this child is having a polyspike, and all she has is a dystonic posturing, which can again be confused. So there is some jerking of the right upper limb, as you can see. And then she has a mild dystonic posturing, which can again be, that is the dystonic posturing, very brief. So it can be confused with an arousal. But actually, it is a nocturnal paroxysmal dystonia, which is a kind of seizure. And this is her polysomnogram, which showed frequent arousal. So you can see frequent arousals in the polysomnogram. And this is the epileptiform discharge, followed by the seizure. This is not a parasomnia. Hence, very brief event, multiple events, you should think of a seizure disorder rather than a parasomnia. Now, this is just to show you the EEG of continuous slow wave, spike and wave. These children will not come with manifest seizures, but they will come with behavioral abnormalities and sleeping problem. They will not be sleeping in the night. And when you connect them to polysomnogram, you'll find generalized 80% of the sleep is occupied by these generalized discharges. So these discharges go away in REM. So you can see the eye channels here at the bottom. There's REM sleep, there is rapid eye movement, and the discharges have gone away. As compared to that, in the non-REM sleep, the discharges are profuse. So REM-related seizures are very rare, and they usually have features which are similar to daytime events, as you can see here. They can be confused with REM sleep behavior disorder. And we know in REM sleep behavior disorder, there is loss of atonia and there are kicking movements, which can be mistaken as frontal lobe seizures also. Now, juvenile myoclonic epilepsy is a seizure which occurs just after getting up. And hence, sometimes it may come to the sleep specialist when the patient is not observed or the caregiver has not seen the seizure and the patient is just incontinent in bed because it has just happened after getting up. So they may present to sleep specialists. Now, as I said, multiple events occur in cluster in sleep. And that is what differentiates a parasomnia from seizures. Interictal discharges also increase in sleep, particularly in non-REM sleep. And particularly, you can see here, interictal discharges going up, whereas in REM sleep, the interictal discharges go down as well as the number of seizures go down. Now, when we make the patient who has seizures sleep deprived, there is a further activation of the interictal discharges by about 60%. I will now move to differential diagnosis. As we can see, sleep and seizures can be confused with rhythmic movement disorder, can be confused with restless leg syndrome, can be confused with sleep talking and sleep starts, which can mimic myoclonus. It can be confused with periodic leg movement disorder. It can be confused with narcolepsy, cataplexy, particularly the cataplexy can be confused with seizures and sleep paralysis, as well as nightmare disorder can be confused with seizures. Hence, wherever a patient whom you've diagnosed as a parasomnia or an epilepsy is not responding to therapy. So suppose you diagnosed a patient as having seizures, and then you diagnosed another patient as having parasomnias, and you manage them appropriately, but they're not responding. That's a sure indication that you should do polysomnography with extended EEG montage. Like you saw extended EEG montage in the polysomnograms, which I showed you. The sleep clinician must do an polysomnogram with an extended EEG montage. So you can see here, this man was on treatment with epilepsy. So he was on treatment with valproate and he was on treatment with phenytoin for these episodes which were occurring in the night, which were clearly sleep talking. So when the patient was referred to us because the patient was not responding, we did a polysomnogram and you can see the phenomenon was happening in REM sleep. So it was a sleep talking which was occurring in REM sleep. Similarly, sleep terrors, they can be mistaken as seizures. Particularly when they occur in children, they can be mistaken with benign Rolandic epilepsy. And hence, you can see here, the child will just get up and scream and shout, and there is salivation. The video is not playing for some reason. So it can get mistaken as a seizure. Similarly, in this child, there is side-to-side movement of the head. This child was the son of a nurse, and the child was again on phenytoin. And all he had was, you can see, stage 3 sleep on extended EEG montage. So there is a stage 3 sleep with high amplitude delta. And the movement is starting from stage 3 sleep. So it was not a seizure. It was a parasomnia. It was a pavor nocturnus, which is a rhythmic head movement disorder, or head shaking in sleep. So all we had to do was stop the phenytoin and give low dose of clonazepam, to which the patient responded by confirming with a polysomnogram. So we had to do the polysomnogram. It was indicated because the patient was not responding to a wrongly diagnosed seizure disorder. This patient had a prolonged episode, which was sleepwalking. The episode actually runs for 10 minutes. I do not have time to show you the whole episode. She actually gets up from the bed and walks. So you can see the episode. Here we are in stage 2 sleep, and you see there are frequent arousals. So she has a disrupted sleep with frequent arousals. And now she's in stage 3 sleep on the polysomnogram, and then she has the movement. So here where she's moved, the movement has arisen from stage 3 sleep. So this is a parasomnia. There is no seizure discharge here, and you can see the stage 3 sleep is continuing and the patient is moving. So this clinches the diagnosis of parasomnia, and the patient actually was on medication for seizures, which we had to stop. Sleep starts are again mistaken as seizures very often, and they present as jerks in sleep. These jerks can be focal or multifocal. And these patients also are wrongly put on anticonvulsants. The EEG correlate is just finding a brief disruption of the EEG background. That is, sleep starts with the disruption of the EMG background. And it can be associated with frequent arousals. Now, this patient has unilateral periodic leg movements. So you can see the left lower limb, the left lower limb is showing a rhythmic jerking periodically. So this is unilateral left periodic leg movement. So bilateral periodic leg movement is not often confused as seizure, but unilateral is often confused as focal seizures in sleep. And this patient was also on medication, anti-seizure medicine. So you can see the periodic leg movements which are happening and which disappear in REM. This is REM sleep and they have disappeared. Similarly, this patient also had unilateral periodic leg movements. And you can see here that the periodic leg movements are occurring in the right lower limb, and she was also on anticonvulsants for focal seizures. Extended EEG montage, you can see the periodic leg movements, which are there at the bottom of the panel. And here is another patient who was diagnosed as focal seizures because he used to have rolling movements in the bed. So This patient never had epilepsy but was on 4 anti-seizure medicine. This is why a common knowledge is required. We observed him, he was coughing and choking like this and rolling. So this is bed rolling movements, otherwise known as pseudo RBD OSA. All this patient had was OSA and he underwent treatment for it and the movements disappeared. So the relationship which is final is what to do when seizures occur in sleep. There can be difficulties in patients. They can have excessive daytime somnolence, which the sleep physician has to manage. They can have unrefreshing sleep because of fragmented sleep, because of seizures. They can have restless sleep and they can have sleep-related anxiety because they know that the seizure is going to happen in sleep. And hence, it's very important to understand that seizures also affect sleep and they also affect the sleep, insufficiency of sleep also affects seizures. It's very important to understand that there's research showing that there is decreased CSF fluid hypocretin levels in patients with generalized tonic-clonic seizures. So sleep and epilepsy are very important research-wise to understand why a particular seizure is happening. Anti-seizure medicines also affect sleep. Almost all anti-seizure medicines will cause increased sleep except lamotrigine and to a certain extent levetiracetam. Most anti-seizure medicines increase sleep and many patients of seizures come to us with excessive daytime somnolence. Patients with sleep disorders with epilepsy can also have obstructive sleep apnea because if they are on valproate, they become obese and they develop obstructive sleep apnea. Hence, it's very important to understand that these patients will often get referred to the sleep physician where a polysomnogram will have to be done. I think I'll conclude. This was our study. Sleep apnea and epilepsy, I told you, particularly those who are male and those who are on sodium valproate can have sleep apnea. And it's very important that we treat sleep apnea in patients with epilepsy because if you have sleep apnea, it will worsen the seizures. And we have used patients with sleep apnea with CPAP devices and they show an improvement of seizures. In fact, adding a CPAP device for sleep apnea and epilepsy reduces seizures by about 30%. Patients with epilepsy are also prone for restless leg syndrome and periodic leg movements. It's very essential that the sleep physician advise patients with epilepsy appropriately because if you can improve the sleep of patients, which is a potent sleep deprivation, sleep fragmentation is a potent trigger. If you can improve the sleep of your patients, then the number of seizures can also come down. And hence, as most patients with epilepsy transgress the rules of sleep hygiene, it's important to explain sleep hygiene to people with epilepsy and sleep issues. So I'd conclude by saying that I hope I've made it clear that sleep and epilepsy have a bidirectional relationship and they share a differential diagnosis. You have to rule out parasomnias, and in patients of parasomnias, you have to rule out seizure disorder. Hence, a sleep physician must have knowledge of abnormal epileptiform discharges in the EEG, must have knowledge of when to do a polysomnogram, must have knowledge of an extended polysomnogram EEG montage, and must be able to interpret or seek help of the neurologist in interpreting such polysomnogram studies. With this, I'd like to thank Dr. Nurul. I'm sorry for the technical difficulties which I faced in the beginning. Thank you, Dr. Nurul.
Thanks, Dr. Manjri, joining from All India Institute of Medical Sciences and throwing light on, neurology and sleep medicine, how this connection and all. May I request my audience, those who are in the meeting room and those who are watching live on ismcon.in webcast, they can unmute your microphone and ask question from here. Dr. Manjri is there. Anyone who want to ask any question? They can either unmute your microphone or they can ask the question in the chat box as well.
May I ask a question?
Yeah, Dr.
Yes, please.
Dr.
Thank you very much, madam, for the enlightening session. It really was a very good information for me. I just want to ask, madam, the patient who were on the anti-epileptics, the anti-epileptics need to be stopped abruptly when they are diagnosed with insomnias or the sleep disorders?
No, we never stop it abruptly, because stopping abruptly themselves can cause withdrawal seizures. Hence, we have to go very, very slow. We reduce by 25% every 2 months or every month. If there is, as I told you, sometimes sleep disorder can coexist with epilepsy. In those patients, you have to be very careful. You would not be stopping the drugs. If after proving that it's only a single disorder, that is, it's a sleep disorder, whether it's a sleepwalking or a sleep terror, or it's a REM sleep behavior disorder, or it's narcolepsy, cataplexy, then we taper one medicine at a time very slowly, not abruptly, never suddenly.
Again, madam, what are the reasons that we miss the diagnosis of sleep disorder in cases of epileptic disorders?
Because we are not asking about sleep. In most medical disorders, most medical disorders are associated with insomnia. So, if a patient has a kidney disease, there is insomnia. The patient has a heart disease, there is insomnia. But I don't think the cardiologists are very sensitized. I'm not saying they don't ask, but they don't do it as a routine to ask about sleep. Similarly, neurologists don't routinely ask about how the sleep is in a patient with epilepsy. Hence, it's very important, as Dr. Nurul said, sleep speciality is not a single domain speciality. Every specialty in medicine should have their physicians interested in sleep, particularly neurology, particularly psychiatry, particularly pulmonary medicine, particularly dental medicine, ENT. So, sleep medicine is an amalgamation of all specialties. So, as the previous speaker was saying, if the polysomnogram shows obstructive sleep apnea, if the patient has retrognathia, if the patient has a mandibular or oral cavity anomaly, I will ask my dental colleague I will ask the patient to go to my dental colleague who is well versed with making mandibular advancement devices or devices which will improve the, bite of the patient, will improve the oral aperture of the patient. So we should have a team in each hospital of these varied specialities. So the polysomnogram is not being done by the dentist. The polysomnogram is being done by the respiratory physician or the neurologist, and then the referral is being made to the dentist, is being made to the ENT surgeon. So it's that's why you need a team approach, and that's why all specialities in medicine need to ask their patients about how their sleep is.
Thank you very much.
Any more questions from audience?
If not, thank you
Yes,
so much.
yeah, there is no more questions. If the questions arise, I'll email to you. I have requested our audience that if you have any question and they are not able to ask here, they can then write the question to us and we'll write it to you so that they might be getting the answers of the queries. Thanks a lot, Dr. Manjari Tripathi, joining from All India Institute of Medical Sciences and sparing your valuable time on say this Saturday. So thanks a lot from our whole organizing committee. So we are having say half an hour break here. After that, we have three speakers from different specialty. Dr. Sapna Sridharan, she is joining from Trivandrum. She is a professor of neurology, Sri Chaitanya Urinal Institute of Medical Science and Technology. And then we have Dr. Seema Sheikh. He is a otolaryngologist, ENT surgeon. He is joining from Pune. Then we have Dr. Kalpesh Talati. He is joining. He is a physician, consultant internal medicine, and he is joining from Ahmedabad. He is in Zydus Hospital. And then the last but not least, lecture by Dr. Anshu Sahu. He is uh, he is uh, he is joining from Hazaribagh, Jharkhand. He is an orthodontist. So we have four lectures. After this break, we'll join again at 2 o'clock. I'm requesting all of you to just leave your message, you are keep logged in and keep your microphone and your camera off. And we join, in half an hour. So you can have your lunch and, take a break, refresh yourself and join again. Thanks all. We are not signing off. It is as it is. We are here. You just keep your camera off and your keep your mute. Thank you.
चलते हैं अच्छा अभी चले जाए ज्यादा ये की करूँ
welcome you all post our this small break, maybe it's lunch break or refreshment break. We have with us two of the speakers who joined in, rather three speakers who are in the meeting room now. I think Dr. Sapna is also joined, our next speaker. Dr. Sapna, are you there? Could you unmute your microphone and open your camera?
Dr. Anwar, Dr. Talati is here. Can you hear me?
Yeah, Dr. Talati. I'm
Yeah. Okay.
yeah,
Sure.
yes,
Okay. Fine.
Yes. Would you like to do a share your slide, or if you want we can test run, and we can because your talk is after these two speakers, like Dr. Sapna and then Dr. Simad Sheikh and then yours. Dr. Sapna, are you there? Could you unmute?
Yes, I've joined.
Yes.
Hello.
Yeah. So let me introduce Dr. Sapna Iyer Sridharan. Dr. Sapna is MD General Medicine, and she did her DM in Neurology. She is Assistant Professor of Neurology at Sri Chitra Tirunal Institute of Medical Sciences and Institute, based in Trivandrum, Kerala. And her area of interest is stroke, sleep medicine, and neurology in systemic diseases. She had published more than 60 papers in international national journals, and she has contributed 4 chapters in various books and all. Over to you, Dr. Sapna. You can share your slide and you can start your talk. You are visible. We are waiting for your slide to be visible.
Okay. Is my slide visible?
Not yet. We are just waiting.
Is my slide visible?
Not yet. I'm just waiting for that. There was a problem of sharing the slide. Dr. Manchi was facing as well. I think there is some problem with Zoom or what's happening.
Can you see it?
Not yet. It's not visible yet. Either Dr. Sapna, you can leave and can join again, because same thing was done by Dr. Manjiri when she is facing problem for making the slide
Okay.
in slide share mode.
Okay.
Yeah, please.
Is it? Can you see now?
No, it's not visible yet.
No.
Yeah. Just disconnect and join again. It will take another
Okay.
30 minutes, 30 seconds or 1 minute. Not a problem. Yes.
Is my slide visible?
Not visible. Apart from you, I have made co-host to Dr. Kalpesh and Dr. Seema, but I removed the co-host, authority, because I think that might be a problem. You are the only co-host in this meeting room, so you can share your slide, but I don't think what is, going wrong here.
By the time if that is not happening, do you want me to finish my talk? If she's having difficulty in getting her thing.
Dr. Seema, I'm just giving her one more,
Sure.
attempt. If she,
Sure.
does,
No
then
problem. I'm
otherwise,
just saying it from the
just-
point of view of the rest of the people
Mhm.
waiting in.
Mhm.
No problem at all.
So we are webcasting our program on ismcon.in on our website portal, and it is also on live on a YouTube. And there are people who joined in a Zoom meeting room as well for asking questions and all. Yeah, Dr. Sapna. Now I think you are successful. It's coming. Yes, it's visible. Good. Could you please make it in the presentation mode, slide share mode? Dr. Sapna, please unmute your microphone. Your slides are visible, but it's not in presentation mode, slide share mode. Dr. Sapna, are you there? Actually, your slides are visible, but we are not able to see you on the room. Actually, could you please open your camera once and unmute your microphone? Yes. Yes.
Okay. Is it visible now?
Yes, screen is visible, but it's
Hello?
not. Yeah, it's not in presentation mode. Can you?
Now it's fine. Now I put in presentation mode. Is it fine?
It is not coming, but it's fine. It's visible. You go ahead in this.
Okay. Sorry for the technical.
Not at all. It's happening. Yeah.
Okay.
Yeah, you start your
So,
presentation.
yeah, thank you, Dr. Nurul, for giving me an opportunity to present on the eve of World Sleep Day. So in the next 20-21 minutes, I will be speaking briefly on parasomnias and how to approach them. So my outline of talk would be briefly the sleep stages and neurophysiology of sleep, and what are the common sleep stage disorders, briefly into non-REM parasomnias, other differentials, mainly sleep-related hypomotor epilepsy. I'll be showing you a few videos which will help us understand it better, and REM behavioral disorders, and how to evaluate and manage them. So this disorder in sleep is well known since prehistoric era. So we know that in 400 BC, Hippocrates wrote, "I have known many persons in sleep groaning and crying out, some in a state of suffocation, some jumping up and fleeing out of doors and deprived of their reason until they awaken, and afterwards becoming well and rational as before, although they may be pale and weak, and this will happen not once but frequently." So this can be a description of REM behavioral disorder, one of the earliest descriptions of REM behavioral disorder. So coming to the sleep stages and the relevant neurophysiology, I will not be going to detail, just a brief overview. So we know that we exist in three basic states like wake, sleep, and in the sleep there is a non-rapid eye movement sleep and the rapid eye movement sleep. So the non-rapid eye movement sleep is again divided into light sleep, which is the N1 and N2, and the deep sleep, which is the N3 stage of sleep. And the rapid eye movement sleep is called, otherwise called paradoxical sleep or a dreaming sleep, when the subject shows a very active EEG, but there will be muscle atonia. So on the right side of the slide, what is shown
Dr.
is a
Sapna, slide.
hypnogram.
Sorry to interrupt. Dr.
Yeah,
Sapna, sorry
sorry.
to interrupt you. Slides are not, I think, moving actually. We are on the first title slide only. Can we go on
Okay.
the next slide?
I
Yes, yes, the
have
fourth one.
moved. Okay.
Yes.
I
Okay.
think with the presentation mode, the slide is not moving.
Okay. Come out of presentation mode is visible, but your slide should move, no? Yes. Yeah, it's
Yeah.
visible. Okay.
Yes.
Hmm.
Okay. So in the right side of the slide, what is shown is a hypnogram. Hypnogram is a graphic representation of the sleep stages through the night. So we know that in the first half of the night, the non-REM sleep predominates, and the red thing that is shown is the REM sleep. So the REM sleep will happen in brief spurts in the initial phase, whereas it lengthens towards the early morning hours. That is, we tend to dream more in the early morning hours. And as we grow older, the sleep becomes more fragmented, but the duration of REM sleep remains almost stable. So one or two slides about the brief physiology. So we know that the ventrolateral preoptic nucleus is the main controller of the sleep-wake cycle, and it is it controls many midbrain and brainstem nucleus. It is situated in the hypothalamus, and it balances one state between the sleep and the wakefulness. So as there is a change in the homeostatic sleep drive, that is once the homeostatic sleep drive increases and the circadian signals also switch one towards a sleep state, there is an activation of the sleep centers and non-REM sleep initiates. And in the opposite end of the spectrum, once alerting signals, that is the circadian light signal as well as circadian alerting signals coming to wake, there will be the wakeful state. And we know that the non-REM sleep is mainly under the monoaminergic serotonergic control, whereas the cholinergic influence mainly the REM sleep. And during REM sleep, there is activation of endomedial medullary neurons, which will activate the downstream somatic motor neuron, leading to muscle atonia, which is a hallmark of REM sleep. So the sleep stage disorders or parasomnias, as per International Classification of Sleep Disorders, are divided broadly into three categories. That is, one is a non-REM parasomnias, then the REM parasomnias, and others. So among the non-REM parasomnias comes the confused arousals, sleepwalking, and sleep terror. All these three are grouped under what is called a disorders of arousal. And the fourth one is a sleep-related eating disorder. The REM parasomnias are mainly three described ones, which well described one is a REM behavioral disorder, which we neurologists tend to see often. Then there is a recurrent isolated sleep paralysis and nightmare disorder. Then other parasomnias are exploding head syndrome, sleep-related hallucinations, nocturnal enuresis, parasomnias due to medical conditions, substance abuse, and unspecified. So what are parasomnias? These are abnormal, unpleasant motor, verbal, or behavioral events that occur during sleep or during transition from sleep to wakefulness. So they can be seen both in non-REM as well as REM sleep. They are more common in the pediatric population, especially the non-REM disorders, whereas some of them, like REM behavioral disorder, are more common in the older age group. The basic pathophysiology is believed to be defective or incomplete transition between the wakefulness and different stages of sleep. And in REM parasomnia, there will be an admixture of wakefulness and REM sleep with deafferentation of locomotor centers, controlling atonia, which results in the EEG showing still features of REM sleep. However, the muscle atonia is lost. So, So this is a video showing what is called a confused arousal. So this is the most common type of NREM parasomnia, which is very common in childhood. Around 17% of children can be affected by this disorder, and it can occur in about 7% of adults. These are partial awakenings which occur during stage 3 NREM sleep, that is a slow wave sleep. So what happens, as you saw in the video, the individual gets up in between the sleep, appears confused, and performs activities like opening eyes, mumbling, without any excessive motor or sympathetic hyperactivity. And this can last for a few minutes to hours, and they may go back to sleep. And usually, subject wakes up next morning and have no recollection of the event. So this is another NREM parasomnia, which is more well described, which is a sleepwalking, something called a sleepwalking. So you can see that suddenly the subject appears to have waken up from the sleep, and they may walk around. There is an ambulatory type of behavior which happens during the event. So when you record a EEG or a polysomnography, what we find is an arousal with an ambulatory behavior which occurs when the subject is in the stage 3 NREM sleep. This can affect about 14% of children and 1.7% adults. It may range from simple acts like ambulating aimlessly to more complex automatic behaviors like playing a music instrument, urinating, or driving, or even moving out of the house. However, this very rarely only results in self-injurious actions, and the subject will have no recollection of the event the next day. It can be triggered by sleep deprivation, drugs like zolpidem, beta blockers, quinolones, and antipsychotics. So this is one of the most dramatic type of NREM parasomnia, that is sleep terror. Here, this may be frightening to the bed partner or parents who sleep with the child as well. Episodes of sudden arousal with screaming along with sympathetic hyperactivity like sweating, tachycardia and tachypnea along with increased motor activity. So the subject appears terrified during the episode and may have a vague recollection of the event. And rarely this needs to be differentiated from sleep-related hypomotor seizures and also post-traumatic stress disorder, especially if this starts in the adulthood. So This is a case vignette. We had a 54-year-old male, diabetic, well controlled with medications, who presented to us with a sleep initiation difficulty, has noticed crawling sensation, discomfort in both legs at night, and needs to rub the legs for partial relief. And he also reported sleep fragmentation with daytime fatigue. So we made a clinical diagnosis of restless leg syndrome, and the patient was initiated in gabapentin. Since he was complaining of significant difficulty initiating sleep, he was also initiated on small dose zolpidem along with the same. After initiation of the medications, we reported the reduction in that restlessness and crawling sensation in the leg, but he started experiencing a new symptom. That is, he started waking up about 1 to 1.5 hours after going to sleep, and he walks to the kitchen and starts eating sweets or butter or raw vegetables. And when confronted by the wife, he sometimes gets angry and insists on eating. And when waken up in the morning, he reports that he cannot recollect the events completely. So this is something called a sleep-related eating disorder. This is another type of NREM parasomnia, which is less common. It is defined as recurrent episodes of involuntary binge eating after partial awakening from sleep, with the individual remaining amnestic of the event. Patients can eat raw inedible material and cause harm while handling knife or sharp kitchen tools. This exclusively occurs in adults with a lifetime prevalence of about 6.5%. It can be triggered by multiple medical conditions like encephalitis, autoimmune hepatitis, narcolepsy, smoking cessation, and substance abuse. And certain drugs are well reported to be associated with sleep-related eating disorder, the commonest being zolpidem, mirtazapine, quetiapine, lithium, and anticholinergic medications. Even though the lifetime prevalence is reported around 6%, this in my clinical practice I have found very rarely. So far, I found only 2 subjects with a similar symptom. The other parasomnias are exploding head syndrome, where the patient hears a loud noise within the head at the onset of sleep. Sexomnias, mostly men engaging in sexual activity during NREM sleep. Nocturnal enuresis, which occurs in children. Sleep talking, and status dissociatus. So when a patient comes to us with a sleep-related parasomnias, the close differential is sleep-related hypermotor epilepsy. So how can these be differentiated? The sleep-related hypermotor epilepsy, or SHE, is a brief event with stereotyped motor patterns with an abrupt onset and offset. It can occur at any age, but peaks usually during childhood and adolescence. And usually the events are of high frequency with clustering as opposed to NREM. Seizures occur predominantly during nocturnal NREM sleep and rarely during REM sleep. And that also, it usually occurs in the stage 1 and 2 of NREM sleep as opposed to parasomnias, which occur during stage 3 NREM sleeps. The primary clinical expression consists of hypermotor events with vigorous hyperkinetic features with vegetative signs like vocalization and emotional facial expression. And if there is an asymmetric tonic or dystonic seizures with or without head adversion, then you think that the event may be more related to epilepsy rather than a parasomnia. So since in our center we have overnight video EEG facility also, when we are suspecting a subject to be having epilepsy versus NREM parasomnia, we usually subject them to overnight video EEG rather than polysomnography. The advantage being in video EEG we get all the channels, whereas in polysomnography we are limited by 6 channels. So here is one of our children who reported with repeated arousals during sleep. So you can see that the child has a stare and a frightful expression, and suddenly waking up from the sleep along with some vocalization. So it is a very brief event with a sudden onset and offset, and there was some unrest responsiveness during that event. So here it could have been confused with night terror, except that the string during the events, and there was some automatic movement of the left upper limb as well. So this patient had a video EG showed a seizure onset from the right temporal lobe. So this is a type of event which can be there is a score called FLEP score, which helps us to differentiate between NRA and parasomnia and epilepsy. So this is a frontal lobe epilepsy parasomnia scale. So here you look at the age of onset, the duration of event, clustering, timing of event, symptoms, the recall of the patient, vocalization, and the total score is given. So this table shows how we can differentiate between the two. The score, anywhere the negative scores are more in favor of a parasomnia, whereas score 1 or above are more strongly indicative of epilepsy. Then there are some other epilepsies which get activated during sleep, like benign childhood epileptic centrotemporal spikes and Landau-Kleffner syndrome. So these EEGs will show the characteristic EEG pattern during sleep, that is frontocentroparietal temporal discharges during sleep with profound activation. And in Landau-Kleffner syndrome, it will look like electrical status in slow wave sleep. So coming to the REM parasomnias, the most well-described one about which a lot of research is going on and is seen clinical practice is a REM behavioral disorder. It is characterized by increased motor activity during REM sleep as a result of dream enactment behavior. It can be in the form of kicking, punching, yelling, or violent behavior which correlates with enactment of a nightmare. It can result in injuries to self and bed partner. And if awakened, the subject will be usually able to recall the content of the dream. And when we record a video PSG, we find the classical finding of REM atonia. And even though the REM behavioral disorder can start in isolation, if you follow them sufficient enough for 10 to 15 years, around 80 to 85% of them will turn over to be one of the synucleinopathies or a neurodegenerative disorder. So this is one of our patients who presented around 12 years back with the history suggestive of REM behavioral disorder. And on examination, other than anosmia, there was no other neurological findings. So at that time, we made a diagnosis of REM behavioral disorder, which may be a prodrome of one of the synucleinopathies. Started the patient on clonazepam, increased the dose up to 0.5 milligram, but she could not tolerate due to excessive sedation in the daytime. Tried melatonin at 6 milligram with mild benefit. The patient was kept on follow-up. After about 10 years, the patient started developing generalized slowing of gait with cognitive decline, and examination showed symmetric Parkinsonism with postural instability and global cognitive dysfunction. So this is a story. If you follow them up, over 80% will convert them into one of the synucleinopathies, like either Parkinson's disease or diffuse Lewy body disease or multiple system atrophy. So this is a polysomnograph of that patient. Here the EEG shows that it's fast activity, just 1 to 2 hertz lower than the alpha frequency. And here we can see the rapid eye movements, and the chin EMG will show the increased muscle activity. So here again, after the brief arousal, again the REM sleep stage is continuing. However, the chin is remaining active. So this is a finding. The REM behavioral disorder, the motor even may not be present on every night. However, this finding can be used for diagnosing RBD. There are two more other REM disorders. One is recurrent isolated sleep paralysis. It is a recurrent inability to move the trunk or limbs at sleep onset or waking up from sleep. Can last for minutes. The episode can cause significant distress to the subject, and it should not be explained by other sleep disorders like narcolepsy. and it needs to be differentiated from other sleep disorders like night terrors, nightmares, and rarely even REM behavioral disorder. And their management includes avoiding triggers like chronic sleep deprivation, which is common for most of the parasomnias. And also, studies have shown that if the subject is lying supine, they are more prone for developing, for getting an isolated sleep paralysis. So, if somebody has an isolated sleep paralysis, they should be advised to sleep in the prone position. Then, bed partners can be instructed to give a vocal or tactile stimulate the sleep offset to prevent or abort attack. And rarely, if it is highly refractory, then subjects can be started on medications like tricyclics, which will work for cataplexy. Coming to the next entity, nightmare disorder. Sporadic nightmares can occur in very commonly in general population. However, persistent can be there in less than 5%. It is more common in childhood and young adults. It increases in subjects with psychiatric illness, history of trauma, and high stress levels. And whenever somebody complains of a new onset nightmare disorder, always screen for any medical history, psychiatric conditions, history of trauma, medical history. Drugs like beta blockers are notorious to produce nightmares. Post traumatic stress disorder related nightmares can respond to alpha blockers. And the mainstay of treatment is cognitive behavioral therapy, and rarely benzodiazepines are given if anxiety levels are very high. Coming to a brief evaluation, a detailed sleep medical history from the patient and bed partner is the initial step in evaluation of parasomnias, because most of the time, over 90% situation, you can get a diagnosis from history alone. Post-traumatic stress disorder, panic attack, and psychogenic spells can mimic parasomnias. Overnight sleep study, polysomnography, and video EEG are occasionally required to identify parasomnias, especially when there is a strong suspicion of epilepsy. And PST can also detect any underlying sleep disorders like OSA, which can produce secondary parasomnias like sleep talking or RPD, or periodic like movements in sleep. This is my last slide. Management, identification and treating any comorbid sleep or medical condition along with the termination of inducing agents. Most of the childhood parasomnias are benign and self-limiting. So reassure the parents, ask them to avoid sleep deprivation. Good sleep hygiene is a must. For adults, environmental safety measures should be adopted. There is a significant role for cognitive behavioral therapy in NRA and parasomnias. Rarely resistant cases may be managed with small doses of benzodiazepine clonazepam, but it should not be given for a long duration. And REM behavioral disorder often requires behavioral modifications along with medications like clonazepam, melatonin, but those with underlying neurodegenerative disorders.
Yes. Dr. Sapna, have you concluded your presentation?
Hello?
Yeah, have you concluded?
Yeah.
Yeah. So I'm requesting audience to ask question. If you have any question, they can ask related to parasomnias, a clinical approach. Very enlightening slide talking all the points related to parasomnias and all. Anyone among us who want to ask any question to Dr. Sapna? So Dr. Sapna, if there is no any question, I think they have understood it well. If there is any question, if you stay with us, they can ask question after
You
this the next
see
topic.
the slides.
Due to connect internet issue, I think your voice is cracking, Dr. Sapna. Thanks a lot for joining International Sleep Medicine Congress 2024.
Could you see my slides and video?
Yeah, it's a visible. The last slide is the management, which is visible. So, Dr. Sapna, should we move to our next speaker with your permission?
I think the laptop is hung up.
Yes, yes.
We are going to have to move forward without that one. I think I'll share screen, then maybe her laptop will be out of the way.
Yes. So, Dr. Sima, before you start, meanwhile, I'm just giving a brief introduction. If you want to add something, you can add further. Dr. Sima Sheikh is a known name in the field of OSA in this country. He has to his credit the dedication and the hard work with which he spearheaded this super specialty and organized it in a fashion where there is no an association for it, which works with the individual in it towards proper guideline formulation. He was chosen as the founder president of IASSA, Indian Association of Surgeons for Sleep Apnea. His basic medical undergrad and postgrad education ended in BJ Medical College, Pune, way back in 1993. He then went ahead to specialize in the science of OSA, taking training from various centers in Germany and Singapore, Norway, amongst many other countries in the world. He is presently based at Pune. He is HOD at ENT Inamdar Hospital, Pune, and consultant sleep specialist attached to KENH Hospital, Pune. He has various national and international papers to his credit. He has achieved academic excellence and he has been invited as a guest speaker and faculty at many conferences and workshops across India and abroad. He is very practical teacher and a very moderate and balanced person in his approach to OSA and to his life in general. Over to you, Dr. Simam.
Thank you, Nurul. Thank you very much for the invite and the opportunity to be here. I'm going to share my screen and then start off. And I think today I'm going to be planning to talk on is the multidisciplinary role, especially of an ENT surgeon with regards to sleep apnea. I'm sure you can see my slides clearly now.
Yeah, it's visible.
Right. So this is my disclaimer right at the beginning that I'm not here as a surgeon to try to show any superiority between surgical versus the medical management. It's always a complete teamwork, and we all need to understand that sleep disorders are multifactorial, and we have a multidisciplinary approach to all of them. My role today is going to try and show you what is the role of an ENT surgeon and how this has evolved over a period of time. So we were not really looking into the right things as ENT surgeons, possibly because as surgeons we sometimes tend to have a surgical ego and don't look into the physiology that much. So we were not looking at the physiological aspects of the disorder, which has now changed. And at the outset, we do acknowledge that presently CPAP machines are the gold standard. That's literature based, and that's what the whole world is talking about. And we do understand that bit and acknowledge that because the UP3, which was the workhorse for us for many, many years, 2-3 decades back, has now really changed, and that had very low success rates back then. And that's the reason why it didn't work. And that's what got us thinking that why is it not working? But at the same time, there was also a percentage of failures, which were either in terms of startup failure or maybe the long-term dropout of the usages. So if you look at these two together, between say 2004 to 2019, this is an old slide. We are almost 5 years ahead now. COVID put us back by 2 or 3 years. But we have to try and understand how surgery has improved and how PAP therapy and its improvement has happened in compliance rates. That would be very much easier for us to understand. And once, as surgeons, when we understand this, I put it up in our association and we put this up in our guidelines that as surgeons, once we do the sleep study, we do the FNLPs, we do the SCOPs, we must incorporate PrEP trials as a protocol before we go ahead and think of doing even the dynamic MRIs or the endoscopy. So we have incorporated this as part of our protocol. As surgeons, we were looking at the levels of obstruction. We knew that the obstructions were either retropalatal, retrolingual, or even pharyngeal. But we started getting more and more specific in trying to locate where exactly the obstruction is. It wasn't just as simple as that. We started to locate it with flexible awake scopies, with dynamic MRIs, and with drug-induced endoscopies. And we not only looked at just the anterior-posterior part, we looked at the circumferential as well as the lateral parts of the entire airway. The UP3 was classically only directed to the anterior-posterior parts. That is why one of the major reasons of failure for that was that. Now, when I started doing a lot of that, we also had one more problem that we were facing. So most of our physician colleagues told me that you may be doing a DICE, you may be doing a flexible scopy, but you don't know at what level of sleep are you seeing the obstruction, because the obstruction changes during different levels of sleep. So this is what I started doing. Then we started doing a flexible DICE, a flexible scopy with a PSG on table, so that on one side I would know at what stage of sleep I'm looking at, and on the other side then I would be looking at the level of obstruction accordingly. And that gave us better and more evidence-based information about the levels of obstruction. And then we started classifying the levels of obstruction, where it was not just about the AP lateral, but it was also the concentric collapse, which was the third analysis. And it wasn't just based on the whole classification, but we got starting to do something like the TNM classification in cancer, where we did something like V2C, O2L, T2, E2AP. So this is, if we have a common nomenclature, then the opposite person that you're dealing with knows very clearly that I'm dealing with a velopharyngeal, a velum collapse, which is complete. 1 into 1 is partial, 2 is complete. And the type of collapse is circumferential. So this is my velum. Oropharyngeal, I have a complete collapse, but it is only lateral. In the tongue, it is a complete collapse, and tongue always has an anterior-posterior, and so is the case with an epiglottis. So this is just a pictorial representation of how we look at it. And then we know that if I'm seeing something like this, I know how I'm going to be dealing with the velum and oropharynx, how I'm going to be dealing with the tongue, and how I'm going to be dealing with the epiglottis. This makes
Dr. Simab, sorry to interrupt you. Your voice is not coming, as it so properly. Yeah.
Okay. Is that better?
Yeah,
now?
it's now better. No, it's better.
Yeah. Okay. So I will speak from this end. So then we also went on to do dynamic MRIs. The dynamic MRIs gave us not just the vertical picture in the sagittal plane, where we knew the level of obstruction, but also in the axial plane. It gave us a lot of information about the exact diameters of the airway at different levels of the airway. So this was a very, very objective evaluation, where we could figure out at what level is the obstruction and how much is the obstruction. And we could then post procedurally exactly evaluate the opening of the airway. As you can see, this is the radio frequency done here at the base tongue and the radio frequency done for the palate. And you can, at that same level, exactly visualize how much is the opening of the airway. We also went ahead very objectively to figure out the airspace. So we did volumetric evaluation of how much the airspace was increasing, and that's when we realized that we were doing better or not. And evidence-based, we were able to then show that those who defer CPAP or those who fail CPAP are definitely doing much better in terms of procedures of radio frequency or anything else that we use. Results are out here for you all to see at the turbinate level. The nasopharyngeal obstructions we could clear with a tubulator. Now we've got the best of technology, and it's bloodless surgery, as you can see. There's no bleeding at all whatsoever, just maybe 4 or 5 ml of blood in the entire scenario. And that helps clear up the entire nasal airway. The other issues where we developed, we became better, was the fact that we were doing nasal and palatal work together. And earlier, there used to be a fear that if you do a nasal surgery and then you pack the nose, the patient is not going to be able to breathe very well post-op. But here I'm just going to show you a small clipping where you do a nasal surgery and you pack the nose, but you still use a nasopharyngeal airway. And you can see that post-operatively, when the patient comes out of anesthesia, exactly how comfortable he is. This is an immediate post-op after extubation, and see how comfortable that patient is. So this takes away the dangers that we were earlier facing by trying to do multiple procedures in the same patient. And it's been amply proven now, it's out there in literature for all of us to know that the effect of nasal surgery on the continuous use of the PAP therapy is also very, very beneficial. So those patients who probably may not benefit from CPAP therapy that well or need very high pressures will benefit a lot if their nasal passages get opened up with whatever we do. And these are systemic as well as meta-analysis reviews that show us everything. There's also a very clear-cut position paper out there suggested by Professor Friedman way back in 2000, where we do nasal surgery just to improve the compliance of the CPAP. It may not necessarily be for the treatment of OSA, but it will be for the compliance of CPAP. We are able to then use a nasal surgery. The oropharyngeal obstructions, as you can see, are very simple to treat now. Again, a very simple bloodless way of just trying to open up the obstructed airway. And we don't even necessarily need to do a tonsillectomy like we used to do. The newer concepts are of a tonsillotomy, where, as you can see, only the parts outside the anterior pillars are removed. And this helps in opening up the airway. And it's a completely bloodless, real-time surgery, takes barely about 5 or 10 minutes at the max. So palatal surgeries have also come a long way. Initially, we used to do a lot of radio frequency. We used to do UP3, which got condoned. And instead, when we realized that everything is related to the palatopharyngeus muscle, we started moving the muscle onto the soft palate, which we named as relocation pharyngoplasty, but realized that it wasn't helping enough. So we found a structure a little more lateral and anterior. And then we started we started hooking it up onto the pterygoid hamulus and realized that maybe that was also not sufficient enough. And then we found another structure, the pterygomandibular raphe, and moved the palatopharyngeus up to there, thereby giving us ample lateral expansion of the wall. So now the algorithm is out there, very easy to decide on this. Since it's not a very surgical audience that I'm talking to, I won't get into the details. But if you see the difference, there is a lot that we can achieve by just doing palate as well as also the tongue-based obstructions that we remove. Now we have the MRIs which tell us exactly how much it removes. We have multiple procedures for the tongue-based, but that itself tells us that not all of them are very good. Then there are simpler ones. For the sake of time constraints and for the sake of a non-surgical audience, I will not get into all of that, but we'll show you some success rates which are evidence-based, right? And you see that excision of the tongue base always gives you much better benefit than just radio frequency of the tongue base. Now, all the procedures are there. They've all been audited. They've all been put in place with regards to the results. And you will find that a lot of tongue-based procedures improves the success rate by a lot, like from probably 15 to 20%, it goes on to at least about 58 to 78% variables. But if I have to say this, like I said, where the role of the person in the ENT department is, we always put it up as the failure of PAP compliance first, as a defined failure. Those are the patients that definitely we are in a position to help. If there is a blockage which is just type 1, only at the palatal level, and then it's quite criminal to let that patient be on a CPAP device all his life. Moderate RDIs, but with severe daytime somnolence, these are the patients that are broadly surgical candidates. What kind of surgery is something for us that we need to look into in detail and then decide. But overall, for a non-surgical audience, these are the kind of patients that we are looking at. But definitely, we will not be touching any of those with morbid obesity. There we ourselves would recommend a bariatric option. Those that are alcoholic or patients with very low motivation and patients who have got many comorbidities and not willing to change their lifestyle issues, these are not by and large good surgical candidates. Surgeries are multi-level. They can be multi-stage at a single stage. So that's the most common concept now that we use. We go step by step. We tackle the nose first, the nasopharynx, the palate, then come to the tongue base, and then the hypopharynx. Out of which we can do 2 procedures of the nose and the palate very easily at a time. And there is a concept of 2 minor and 1 major, which I think is beyond the scope of this particular talk of mine. The success rates, what we kind of define, are pretty much the same as of now, which have been proposed by Sher et al. But there is a slight change in our perception, because this is something that I would really like to bring across to all my non-surgical colleagues, that we cannot base our success rate based on just an index of AHI and say that if AHI improves by this much, we are successful, because we are dealing with a complete different class of a patient who's got multiple issues with quality of life. So for example, let's say I have a patient whose AHI is 100 and post-operatively, the AHI comes to 50, but the patient has improved a hell of a lot with his quality of life and his airway and the saturation levels. We can't really call that as a failure because it doesn't fit the criteria of AHI which is being given by Sher et al. So it makes more sense for us to have a broader criteria for defining a success of treatment. And this would involve improvement in general quality of life quotient, and that would encompass everything, including what is now being called as the sleep goal criteria. So where we encompass not only the AHI, but the saturation, the weight, the sleep quality with questionnaires, improvement with CPAP compliance, bringing down the pressures of the PAP machine. These all are improvements in the patient's for the patient's benefit. So definitely these are successful if that surgery can help you do that. Because, for example, if I have a patient who's come to me at this level and I define this as cure, insignificant improvement, or sorry, significant improvement, improvement, and failure. And if I have a patient who's presented to me with this level, but post-operatively has come down to this, but is not in the cure target in all the senses, but has improved so much, then definitely this is success. That is why we bring out this sleep goal criteria as a success, which encompasses everything: latency of sleep onset, the quality of sleep based on Epworth sleepiness score, the BP, the gross BMI, the oxygenation, the AHI, and the quality of life quotient. This is a far better way of looking at success rates, although it is not as simple as probably just an AHI to say pass or fail, but there are a lot of other issues. But I would like to come towards the end with a caveat to make you understand that although as an ENT we have a major role to play, there is a lot of pathophysiology of the OSA where we don't come into the picture. That is this part. We come into the picture only as far as the obstruction is concerned, but we are geared up now to deliver fantastic results for the obstruction, evidence-based results for the obstruction, and complete improvement in a lot of parameters when it comes to opening up the airway. So my strong take-home messages would be to understand that you do need an ENT surgeon in your team when you're dealing with sleep-related disorders. And more importantly, he is in fact the first person that should be sought after in your team. When you see a patient, you see a sleep study, and before you even think of a CPAP trial, you must ask your colleague ENT surgeon to have a look. Because if you get in a situation like this, all I need to do is just do a flexible scopy to see that the epiglottis is like this. But if you put this kind of a patient on a CPAP machine, that patient is going to suffocate more than actually get benefited out of it with this falling epiglottis. And unless and until I clear that epiglottis for you, then that patient is not even going to benefit from that CPAP therapy. So even before you offer a CPAP trial, awake flexible scopy is an OPD procedure, which is not a very big deal. And that's something that you must get the person to get done. Just as the ENT surgeon is we have informed everybody, you must get a PAP trial done before you consider doing the DICE. So all in all, we have a very major role to play in the identification of the site of obstruction, in the removal of obstruction in well-selected cases, And we're talking about removal of obstructions even beyond the palate. So UP3 is totally passé. Nobody does UP3 anymore. And we have a very, very important role in helping to improve PAP compliance and to downgrade the severity of OSA. A few people whom I have really learned from, Professor Vicini from Italy, Professor Good from Stanford. And I would like to just be open to questions to try and explain to anybody what the role of an ENT surgeon is. Because this is a branch where the more you tend to know, the more you realize how much you don't know, as compared to what we used to think that we know a lot about this particular. Thank you very much. I'm open to questions if there are any, and would love to interact with the different faculties that are present.
Thanks, Dr. Simab Sheikh, for throwing light on, importance of, surgical management in OSA. And, so anybody who want to ask any question, Dr. Simab is there. He's, pioneer in working, exclusively in this, OSA domain. And so that anybody who is, we have a privilege that Dr. Simab is with us, so they can ask questions.
Sir, I have a question.
Yes, please, Dr. Badar. Please go on.
What are the different ways to know the site of obstruction, actual obstruction, and that easily available for the patient?
Yeah, so that's what I mentioned to you, that one of the easiest ways is a flexible awake scopy that will tell us in a lying down position very much a good idea about, because you're passing the entire scope through the nose, nasopharynx, oropharynx, and down into the hypopharynx. So it gives us a pretty decent picture. Of course, that's not like to say that we base our decision making just on that. But if you finally sit down and counsel the patient and explain to them, willing to then go ahead for any kind of procedural intervention, that's where then the role of the DICE or the dynamic MRI would come in. But in the first stage itself, it's extremely important to do a flexible awake scopy, because even if you are not an ENT surgeon and you want to offer a PAP therapy to the patient, and that patient is not going to benefit with that because of a collapse at the level of the epiglottis, then you need to know that. So there are 3-4 ways. One, like I said, the simplest is a flexible awake scopy, which is available in almost a lot of ENT departments now. Our ENT colleagues have flexible scopes. And then there is, after that, there is DICE and dynamic MRI. These three give us very clear-cut ideas about the exact level of obstruction. I hope that answers your question, Badar.
The dynamic endoscopy, I think it will be more preferable that if you do it with a surgeon, ENT surgeon, who is more versed with OSA and all those things.
Definitely. I mean, you have to have somebody who is going to be able to interpret that scopy for you, no? And there's one thing about doing a scopy, but one thing is about interpreting. So the same applies to dynamic MRI. You can get a dynamic MRI done, but if you don't know what information to derive out of that, then it's a waste of a test. And in today's date of practice that we do, your every investigation has to be justifiable to the patient, because there is a cost factor attached to it. So you can't say to the patient that I want to get this test done, and at the end of it say, oh, I really don't know, we need one more test after this.
Thank you, sir.
Thank you.
Thanks, Dr. Badar, for asking question. Anyone else apart from Dr. Badar who want to ask question to Dr. Simab Sheikh?
That's
So
great.
no more question. Yes, Dr. Simab.
Thank you so much, Nurul. I must compliment you on the efforts that you've been taking. This is the 3rd year in a row consecutively that I'm happy to be a part of this. And this is the way to make things go forward and have people interact and understand the multidisciplinary approach, so that we can make a difference to this major sleep issue. And I'm really glad that you got me on board. Thank you very much. Always accessible if you would like to get in touch. Thank you.
Thanks, Dr. Simab. If you wish, you can stay with us. We are moving to the next speaker with your permission, Dr. Simab.
Yes, please. Yes, please.
Yeah. So our next speaker is Dr. Kalpesh Talati. and he is working for long in sleep medicine. He is a consultant internal medicine physician in Zydus Hospital, Ahmedabad. Over to you, Dr. Kalpesh. You can share your slide and you can give your own brief introduction before starting.
Yeah, just a minute, just.
Yes, yes.
Yes, I'm trying to share my slides.
It's visible, but Zoom is coming. Can you
Yeah.
Yes, your desktop is coming. Yes.
Yeah. Now you can hear me, right? Hello.
So yes, you're audible and your slide is
Yeah,
visible.
I am audible. Yeah. I am Dr. Kalpesh Talati, Zydus Hospital, Ahmedabad, working in Ahmedabad Zydus Hospital as a internal medicine guy and sleep specialist. Thank you very much for Dr. Nurul for organizing this web meetings, and it's really a wonderful trial on the line. Today, just we go for the shift work and sleep. So today's talk is mainly on the So just what is the shift work disorder? It's a circadian rhythm sleep disorder characterized by a misalignment between the body and the circadian rhythm, which regulates the sleep-wake cycle. And different circadian rhythm disorders are there. One is a delayed, second is an advanced sleep-wake phase syndrome, irregular sleep-wake rhythm disorders, and jet lags. How to consider there is a shift work disorder? If the person who complains about the symptoms that occur for at least 1 month, despite the attempts to get enough sleep each day, and then we can say, okay, he has a shift work disorders. In circadian rhythms, they are largely guided by the natural lights and darkness. During the day, the retina in your eyes, which perceives the sunlight, and it gives a signal to the brain and releases the hormones like cortisol and everything from the pineal glands. There is a which alerts the person as well as you feel the energized. As the sun sets and light fades, your brain produces melatonin, which induces the feeling of sleepiness and relaxation. Shift work scheduled work between the 7 a.m. and 6 p.m. That is called a scheduled work. But out of that time, that is called a shift work. It can be permanent night shifts, afternoon or evening shifts. Shifts begin before the 6 a.m. These are the different shift works. There is a condensed work weeks with the extra long weekends, variable or rotating shifts like day to evening or day to night, and may change weekly or monthly. Critical services for 24 hours basis like police, fire, military, healthcare like doctors, utilities, transportations. These services people may require for 24 hours. And that is the reason shift work is needed in our social life, even in the industries, because they have to run continuously for 24 hours for the demand of the uh, uh, things, and just to make a profitable or sustainable business. That is the reason they need a shift work. Who does the shift work? Men, they are more doing shift works and majority in the night and rotating shifts. Women, they are also doing in the evening and part-time works. Younger, more than the elders. Single, they are more than the married persons. And single mother, more than the married mothers. These people are doing the shift works. What we should know about the shift works, whether it is a permanent or rotating, and how long, how many hours we have to work, and how many days before a rest day, how many rest days on a weekend, whether it is a overtime, length of the rest between the two shifts, is there any rest during the shifts, and is the schedule is regular or predictable. These are the things we should know about the shifts. Permanent nights. Most permanent night workers, they never get used to the schedules. Many nights they feel tired and sleepy, fatigue because of the return to the day hours or day off. Family and friends, there is an active life, errands and course during the day, and sleep during the day. Rotating shifts can never adapt to a set work schedules, used to more fair to all workers. And rotating shift workers have more complaint than others about the physical as well as the psychological health. Shift works, it depends on the speed also, how fast they are rotating and how fast you are changing it. And the direction is very important in a forward like clockwise, day, evening, and night, and reverse like day, night, and evening. So these are very important things for the we should know about the sleepers. Whether it is a long rotation like 3 to 4 weeks or like it is a short duration like 1 to 2 weeks. Longer rotations may allow better adaptation for the shift, and shorter rotations allows no time to get used to the night shift, but can get through it very quickly and use more in the Western countries, even in our hospital and everywhere they are now using it. Unpredictable schedules, like any emergencies, healthcare workers with the emergencies and factory breakdown and other any emergencies, we have to change the shifts, and that is an unpredictable schedules we can plan. How does the body work? There are the two mechanisms, external and internal. Internal is a biological clock and circadian rhythm regulated by the sunlight and darkness and other factors. That is called external clock. Here we can see the circadian clock affects the daily rhythms of the our daily routine, and that changes the physiological changes. The diagram shows the circadian patterns of the typical of someone who rises early in the morning, they take their lunch in the afternoon, they take their sleep in the night, along with the other factors like light, meal, stress, exercise, family activities. They affect the timings of the sleep as well as the circadian rhythm. Different body functions, they have a very different presentation during the 24 hours day. Metabolism is greatest in the afternoon and in the evening. The most people, they are most alert at around 4 to 6 p.m. and most sleepy in the morning, that is a 4 to 6 a.m. And that is very important in this shift work presentation. Cardiac body rhythm, circadian body rhythms, they affect the lots of factors like hormonal and gastric secretions, bronchial reactivity, blood pressure, sexual arousals, anxiety, work performance, short-term memory, family interactions, metabolic rate, and the body has a natural cycle of the 25 hours. But our internal and external factors, they synchronize us for a 24 hours day. So the internal clock is located in the suprachiasmatic hypothalamus on the both the sides. External clues like Z-jabbers, like dark and light cycles, timing of the meals, social interactions, and the actual time clock, that are the factors for the external clues. In all shift workers, we just notice the sleep hours in that case. So night workers get the least sleep, around 6.6 hours. Evening workers, they get the most sleep, more than 7 hours. And day workers, they get the minimum amount of sleep. But the rotating workers, they have a less hours of sleep. Usually shift workers, they have a loss of sleep around 2 to 3 hours. That is in a conventional way. And it is lighter sleep and more easily disturbed by the noise. There are more activities and noise during the day. After shift, there is a sleep during that time, shorter and less satisfying and refreshing. Delta sleep is also disturbed, so repair and maintenance functions will be affected. Sleep loss makes easier to fall asleep at inappropriate times, will decrease the concentration, increases the accidents. Sleep can occur in short episodes lasting a few seconds without even realizing it. That's a micro sleeps, what we call is. That is very dangerous. Night workers have a drop in alertness at 2 to 4 a.m. in the morning. So accidents can occur at that time. We have noticed the previous accidents like 3 Mile Islands, at Bhopal accidents, Chernobyl, and the Exxon Valdez oil spillage. These are all occurred in the early morning between the midnight and 4 a.m. Sleep deprivation, if you consider 4 hours per 24 hours, 6 days continuous monitoring of the sleep. So that causes the changes in the sleep architecture, and it may be similar to almost the person who is suffering from the depression. Changes in the hormonal and other secretions like melatonin, cortisol, thyroid hormones, leptins, prolactin, and growth hormones. What happens if we remove the cues and disturb the internal clock? There will be a desynchronosis and entrainment. In desynchronosis, core body temperature and digestive secretions may remain nearly to daily mean level. But when the person has a problem in entrainment, then there will be a different physiologies, may entrain at a different rates, and we may lose the normal phase relationship of one to another. What are the signs of desynchronosis? There will be a sleep disturbance, short-term fatigue, irritability, loss of appetite, and judgment alterations. In dark sleep, trigger the low blood pressure, low heart rate, low birth rate, temperature goes down early in the morning, and slow digestion will be there. Two physiologies most critical to work and safety are core body temperature and sleep wakefulness. In rotation, while forward rotation works better with the circadian rhythms of the body, the reverse rotation is more common in Western countries, but people are not happy with that. Clockwise shift rotations, phase delaying will be there. So it less strenuous and it matches to the internal clock. Higher worker satisfactions, fewer health complaints, and work schedule will be reduced like a complaints. So 20% productivity will increase in comparison to the phase advanced shifts. Counterclockwise, the phase advancing phase. So for every 1 hour of advancement, a full day is needed for the entrainment. And 25% workers may not head up this phase advancing phase. In air travel, if you travel towards the westbound, then entertainment is much easier. And if you travel towards the eastbound, the entertainment is not that much easier. It will be very difficult. Night persons, those who have a night, we known as a night owl, adapt better to the night and rotating shifts rather than morning larks. Rotation every 21 days result in 70% few complaints than every 7 days. So it is more convenient to continue for a 21 day shifts. Health hazards, major is a gastrointestinal, cardiovascular, sleep itself, drug and alcohol uses, risk for prolonged exposure to the chemical and biological substances and other hazards on effect of the pregnancies. In digestive, there is an increased incidence of the ulcers, often at night when digestion and other body functions are slowed down. may eat less nutritious foods at night, drink more coffee. They also go for the smoking and tobaccos and everything. So 75% of the night workers versus 25% of the day workers, they have a digestive issues more with that. Cardiovascular problems, there is increase in the incidence of the ischemic heart disease. Along with that, there will be an increase in the triglyceride levels, even the circadian blood pressure disturbance will be there, irregular pulse can be there. Shift workers were found to have approximately 25% greater chances of developing significant hypertension than non-shift workers. Cognitive ability will be the same thing, more with the shift workers rather than non-shift workers, and increase with the duration of the exposure. Psychological, more depression and despondency, more likely to use the psychotropic drugs, and may require more hospitalizations, will have magnification of underlying depression and bipolar disorders. Circadian rhythm disturbances may be a cause for the depression also. Social risk will be there because the person will miss the family and friends, would rather lose sleep than miss the social opportunities. Some activities are flexible and some activities are not flexible, so they cannot match with all these activities. Social impact, it can lead to the divorce, family violence, social isolations, sexual dysfunctions, may affect women more than the men. Circadian rhythm related to the issues like bronchial activity increases early in the morning, so they may aggravate the asthmatic attacks. Shift work increases the glucose levels in insulin-dependent diabetes. So one study shows 35% increase in risk for developing diabetes. Sleep deprivation lower the seizure thresholds, increase the frequency of migraines, and those are taking some medications, the absorption, excretion, metabolism, and peak effects of the medications will be affected. Shift work disorders itself causes the sleep problems like circadian rhythm disruptions, insomnia, disturbed sleep schedules, reduced performance, difficulties with personal relationships, irritability. Sleep apnea increases in comparison, it doubles in comparison to the general populations, increases the accidents, that will be like vehicle accidents as well as the factory accidents, because the decreased vigilance, lower performance, higher error rates, and 20% increase in ergonomic workers compensation cases they have noticed. So how to deal with the shift worker problems? So first is the administrative controls, limit the shift work to essential jobs. Schedule toughest, most dangerous tasks for early in the shift, less demanding tasks for the later in the shift. Avoid scheduling demanding or dangerous tasks at the beginning of the early morning shifts before 6 a.m. shifts. We should supervise the people more early in the morning around 3 to 5 a.m. Younger workers, they should be monitored, and older people, they should be monitored in the end of the shift because they do more accidents in the end of the shift. So supervising for all these people is needed. And we should encourage them a good eating habits at night, encourage the light meals and nutritive food in the night, allow the adequate meal and rest during rest breaks during the work, have other good emergency plans in that case. There should be a companies or industries then they should keep a boards like that. They should give a tea breaks, coffee breaks, smoking breaks, lunch breaks, or toilet breaks in between the work, because people need that breaks because of the monotonous work. Odd shift out. So complex work shift like 3 to 4 days of 10 to 12 hour shifts. If you work for 10 to 12 hours only for 3 to 4 days, it is a more time saving. And between the work schedules, you will get a more time more opportunities for the family and social activities. But that will lead to the fatigue will decrease the performance by the end of the shift because of the long hours. Daily exposure to chemical, biological, and physical hazards may increase, and some families may have a trouble for schedule like child care, elder care, or any family activities or family affairs. Permanent afternoon, evening, or night shifts more adjustable, but the disruption to the social life and permanent night workers may accumulate a greater sleep deficiency over time. Rotating or variable shifts, length of rotation, workers rotated to a new shift scheduled too rapidly or without sufficient break may have a trouble in functioning. Speed of rotations, longer rotations like 10 to 14 days may allow more time to adjust, and circadian rhythm may require 3 weeks to fully adjust to a new shift. So mental function adjustment will be very good. More trouble with the first 4 shifts, but the later on they will be adjusted very fast. Faster rotations allows workers to get through the more difficult night shift rotation quicker. Direction of rotations, that is very important. Clockwise rotations from morning to afternoon to night causes fewer problems, while counterclockwise rotation, they create more problems. During this shift works, night traffic should be reduced, noise should be reduced, distraction should be reduced, and the working area should be very brightly light, reduce the glare and effective surfaces. If feasible, allow workers to play music that will keep them awake. Maximize the safety and health controls like good ventilation they require, temperature control they require, machine guarding should be there, and avoid the isolating workers. If workers are working together, then they have a communication, they can talk each other, they can share at the time. So sleep micro sleep will be prevented, and provide the food preparation areas like rest areas. Uh, Consider the exercise facilities also. Workers' education and instruction is required. They should be aware about the what safety and difficulties with the shift work. What are the health issues they are going to face? So that things should be keep aware them, and emphasize the accidental risk, performance risk. Teach employees to recognize the social and family problems, how to recognize the health problems which may be related to the shift work, and how to control the shift work hazards and methods that can be used to do so. Minimize the effects of shift work on themselves. Protecting their sleep periods, maintaining the regular rest, vague routines, avoid exercising for 2 hours before going to bed, keep light out of the bedroom, disconnect the phone, maintain a quiet sleep area. When they are going from workplace to home, they should wear a dark goggles so they can have a less light exposure. Eat nutritive meals, keep a regular eating routine, select the foods high in carbohydrate rather than heavy fatty, high protein meals before sleep. And they can use the molecules like modafinil and melosate. Modafinil can be given before the shift starts, and melosate can be given at the morning when they reach to the home just to delay the phase. So these are the medications can be used, but the important part is how to improve the health and how to improve their knowledge about the shift work. That is very important at present. And the rotating shift from morning to night, that is a good thing, as well as the long term, like more than 2 to 3 weeks, shift works is very important. This is the message for the shift work people. Thank you very much. Hello.
Yeah, thanks, Dr. Kalpesh, for
Yeah.
sharing your enlightening presentation on shift work sleep disorders. We are a country where there are multiple sleeps. The shift workers are working across India. There are lot many industries, railways, this airports, aviation industry. They all are working in shift sleeps. So it's a great to they have given the strategy to manage these shift because we are the essential jobs and we can't go it for we can't shut that operation, and also we have to select this opt for sleep shifts and all. Any audience, anyone want to ask question related to shift work sleep disorder with Dr. Kalpesh Talati? You are facing the patients who are having insomnia, those who are working in shift job actually, especially the night shift and all. So you can get the great insight, deep insight from Dr. Kalpesh. So no more question, Dr. Kalpesh Talati. Thanks for joining us in the International Sleep Medicine Congress. And
Thank you, Dr. Nurul, for arranging this good
yes,
conference
yes.
and everything.
Stay
you
with
very
us.
much.
We have the last but not least speaker who is an orthodontist who is giving the insight on how to manage this sleep disorders and all, and what is the dentist role in that. Before we should go to the next speaker. I just want to take the permission of Dr. Kalpesh. Dr. Kalpesh, shall we move to the next speaker?
Sure, definitely. Thank you.
Yeah. Thanks. Dr. Anshu Sahu, are you there?
Yes, sir. Good afternoon, sir. Good afternoon, everyone.
Very good afternoon. Very good afternoon. Yes, I think your slide is visible.
Shall I start my screen sharing?
Yes. Yeah. You can share your slide. Screen share. Yet to be visible. Yes.
Can
So
you
before
see that?
going to yeah, it's visible. So Dr. Anshu Sahu, he is from the organizing committee, and he is organizing secretary of this International Sleep Medicine Congress. He is head of the department, chairman of the Department of Orthodontics and Dentofacial Orthopedics in Hazaribagh Dental College, Jharkhand. Yes, over to you. His special interest area is sleep medicine. So over to you, Dr. Anshu. Before going to start with your presentation, you can give your brief introduction and then move to your presentation.
Good afternoon, everyone. Am I audible?
Yeah, you are audible, Dr. Sahu.
Thank you, Dr. Nurul, for giving me an opportunity to be present here. I would like to extend my thanks to your organization, Ismcon, and I welcome all my listeners here this afternoon. Thank you for joining us. My name is Dr. Anshu Sahu. I'm the head of department of orthodontics in Hazaribagh Dental College, and it's been 15 years now that I've been in academics, and it is a pleasure to be presenting in front of an august audience. And I was going through all the presentations that we had this earlier, and they were all highly educative for me, and I'm thrilled to be here today. I also happen to see my mentor, Dr. Reena Madam, is also with us, and she was the person who instilled the study of sleep apnea in me. And thereafter, we have been doing a lot of programs in sleep apnea, management by dentists. I'll be talking about that in a few seconds now. So much so that one of my PG students now is doing a library dissertation on obstructive sleep apnea and the role of orthodontist in it. With that in mind, Dr. Nurul, I will take your permission to start.
Yeah, you can start, sir.
Okay, sir. Thank you. So we are talking about sleep apnea management, prerogative of an orthodontist. Here I would be taking us through a journey of what is sleep apnea, which most of us have already listened to, and our eminent speakers have covered it already. So I'll be focusing more on what a dentist, what orthodontist role is there in the management of sleep apnea. As we all know, human beings spend approximately 1/3 of their life sleeping, and the quality of life gets affected by the quality of sleep. Sleep, as we know, is a recuperative thing. It heals our body, mind, and soul. It is essential, and as we know, there are two types of sleep, that with REM and with no REM. The whole thing is that less sleep will lead to various complications in our daily life. We all agree with that. The sleep disorders of the upper airway result from any condition or disease that causes partial or complete obstruction of the airway when the patient assumes a supine position and goes to sleep. These are the introduction which we have already covered, so I'll be not going through them more. Some things are there already. Now, sleep disruption is caused by breathing disorders which are potentially life-threatening and has become an important global health issue. These sleep disruption causes are snoring, upper airway resistance syndrome, and obstructive sleep apnea. On physical examination of a client who walks into our clinics, we can very well suspect an underlying case of sleep apnea by these following things: the client being obese, having a large neck girth, having a small jaw or a micrognothia, crowded airway, crowded tooth and leading to obstructed airways, enlarged tonsils, high arched palate, nasal deformity. These things, if we see in the patient, we may think of the patient may have a sleep apnea. There may be comorbid conditions like resistant hypertension, recurrent atrial fibrillation, stroke, myocardial infarction, pulmonary hypertension, chronic heart failure. They may or may not be present in the past medical history of the patient. As we all have gone through, we know that three types of sleep apnea that we're looking at: the central sleep apnea, the obstructive sleep apnea, and the mixed sleep apnea. What a dentist's role is that here is only on obstructive sleep apnea, that management of the obstructive sleep apnea, which a dentist or orthodontist is able to manage in a clinical setup. Since we know the common symptoms of OSA are loud snoring, excessive daytime sleepiness, feeling of choking, restless sleep, unrefreshing sleep, and nocturia, apart from other symptoms. The patient coming to my clinic or our clinics are mostly complaining of morning headaches, constant cough, nocturnal sweating, symptomatic esophageal reflux. And this lead to the risk factors are systemic hypertension, depression, stroke, angina, and cardiac dysarrhythmias. These are the risk factors for obstructive sleep apnea. Day to day, the effect of obstructive sleep apnea is as follows, which our clients generally tell us about. And we have to educate them also that there are chances of higher motor vehicle accidents, poor work performance in school by the students, poor work performance in the office by adults, and of course, occupational accidents. These are serious causes which may be leading due to the obstructive sleep apnea if left undiagnosed. And as we all know, the chances of diagnosis is very low unless the patient attends or meets a pulmonary medicine specialist or a sleep medicine specialist or a chest physician. Till that time, he or she is not aware that he or she is having a underlying sleep apnea. So mostly I want to emphasize here is that the OSA goes undiagnosed, and so happened with us also when we saw a lot of patients in our clinics. And then we did a study and found out that there is underlying sleep apnea in certain patients. Now, as we all know, who does the treatment of obstructive sleep apnea? It is primarily you pulmonologists, you chest physicians are there, sleep medicine specialists are there. This is has been the prerogative of that these departments. Essentially, it is a very critical department and it has been taken care of very well. So the most common devices that we see around which is used are prescription of CPAP device that involves a sleep study, sleep lab study overnight for the patient. And after results have come, the patient has to go through the CPAP device has to be worn by the patient. Then there are definitely huge benefits of that. The quality of life is better, patient is able to sleep better, has more focus on work, has got no daytime sleepiness. No doubt, the CPAP machine is a fantastic therapy for people with sleep apnea. As we all know, there are certain limitations of sleep apnea device, that is a CPAP device. It is mainly three discomfort that the patient has got. First is discomfort in using the device. It takes time to adjust. Here, I would like to tell one more thing. I myself was a patient of sleep apnea. A lot of snoring was there. I started with this device, and definitely I got adjusted to it. It took time. Second thing is that the financial load is very high of this device, as we all know. It's an extremely advanced device, and there needs to be proper care of that device to be taken. And in our Indian scenario, it is not possible, especially in Hazaribagh, Ranchi area where I work. It is not possible for my patients to take these devices. Then there's a problem of carrying the device with yourself when you are traveling. There are certain demerits, certain limitations, but however, it's a fantastic device. I have to admit that. So, what does the when the patient walks into our clinic, we see the patient has got retrognathic mandible, retrognathic maxilla, localized neuropathy. Yes, sir. Hello. Am I audible? Mr. Nurul? Dr. Nurul? Dr. Nurul? Dr. Nurul, am I audible?
Yes, sir, you are audible.
Great, great. So, okay. So, we have got patients with obesity and localized neuropathy. These are the craniofacial anomalies seen in the OSA. Here, we start our journey of getting involved with having the ability to give some kind of treatment to our patients. Based on the cephalometric and morphometric analysis, patients with upper airway sleep disorders can be grouped in three groups, as we know. The one is non-obese, who have got retrographic maxilla. Second is inferiorly positioned hyoid bone. Third is retrographic mandible. Fourth is enlarged tongue and soft palate. And fifth is narrow posterior airway space. These are the patients who are having this kind of sleep disorders. And second is obese with craniofacial abnormalities. And third is the obese with normal craniofacial anatomy. These patients have got truncal obesity and enlarged neck circumference. The girth is increased of the neck. So the common diagnosis and treatment protocols goes as follows. The BMI is taken, the alcohol consumption history is taken, this sleep position is observed and taken note of. Then there is a use of sedative usage, sedative medicines are being used. Then we ask the patient about the frequency and intensity of snoring. Then we have the very vital strong point, which is the Epworth sleepiness scale. Then there are certain investigations like PSG, dynamic MRI, and CT scans. These are very well undertaken by the sleep medicine specialist practitioners. What we have here is a lateral cephalogram. That is one tool that got me interested in this topic, apart from other things, because this lateral cephalogram, as you can see here, it gives us with this lateral cephalogram, we can examine the upper airway, craniofacial anatomy, and the soft tissue analysis. We have got the cephalometric tracing, and with that, we can easily make out what is the nasopharyngeal airway space, what is the middle airway space, what is the velopharyngeal airway space, and the posterior airway space. All these kind of spaces can be determined with the lateral cephalogram. I have to mention here to my learned colleagues and seniors here that lateral cephalogram is one thing that we see every day. For every orthodontic patient, we have to we have to write down, prescribe a lateral cephalogram. And when the lateral cephalogram comes in, we can do the tracings very easily. It's a very routine thing for an orthodontist. So the management protocols are four. First is behavioral modification by way of body weight control, sleep position change, and stoppage of the sedatives or alcohol consumption. Second is, as we discussed, CPAP device. And third is the surgical procedures, which involves the role of the ENT surgeon, wherein the following things takes place with the ENT surgeon's office. There's the pharyngoplasty, palatoplasty, hyoid suspension, tongue-based suspension sutures, genioglossus advancement, midline glossectomy, maxillomandibular advancements. These things are being undertaken by the ENT surgeons as well as maxillofacial surgeons. These are the surgical procedures. So as we see, first is management protocol is behavior modification. Second is CPAP therapy. Third is surgical procedures. And the fourth, and what we have been using is the oral appliances. So this is what I'm here for. Why we have a role in management of OSA and how we do it. Why is it related to mouth? Why we need to study and how it comes to be looked at by an orthodontist. Our field, our prerogative. Yes, to a certain extent, we have an important role to play in obstructive sleep apnea, primarily because of what we discussed earlier. The devices are expensive, the carrying part is little discomfort, and most people come to know about it very late in life. So we looked into it, found that we could have a role into it, and that's how we have come up with this presentation today. As we are aware of the maxillofacial region, we are dealing with the study of the cranium, the floor, the maxilla, the mandible, and the neck on a day-to-day basis. We have got access to the lateral cephalogram measurements. We have got the training to diagnose and look out for DNS, enlarged tonsils, enlarged adenoids, short and thick neck, and definitely micrognathia. Of course, these are like a deviated nasal septum is a prerogative of the ENT surgeon, but we have got a training to look into it as well. This training has led us to look into the device planning also. What our role happens to be is first is the identification of the problem. If we are able to identify or not, that is a primary concern. Because as orthodontists, we are trained, but are we trained enough to identify? Yes, an orthodontist has an ability to evaluate for tongue size, air space evaluation between soft tissue palate and tongue. How do we do that? We can use the Malapatti scores, where we can see the uvula visibility and write down the Malapatti scores. Second is the tonsillar grading, because we can see the tonsil. Third is the periodontal condition. And the fourth is if there is a presence of narrow arch form of a patient. So there is a definitive role of an orthodontist. An orthodontist or a dentist is well positioned to perform an OSA screening assessment and refer the patient for diagnostic evaluation. The role of orthodontics in pediatrics and adult OSA is profound. The orthodontist is able to perform a clinical risk assessment for OSA by asking leading questions. He or she is involved in treatment of skeletal discrepancy. We can move the jaw forward and backward in a non-growing patient without surgery and in a growing patient with or without surgery as well. We have the ability to plan and manage mandibular deficiency in growing children. We have the ability to plan functional appliance therapy. We have the potential to prevent obstructive sleep apnea in adults if diagnosed early. And definitely, as I have been doing since last 7-8 years, referring our patient who are having a history of snoring, obstructive sleep apnea, to our pulmonary consultant, to sleep medicine labs, to ENT consultant. So a referral is generated from the orthodontist. And definitely we play an important role in improving the quality of life of the patient. We can help the sleep physician to analyze the craniofacial anatomy of upper airway. We can design and fabricate oral appliances for mandibular advancement, because the moment the mandibular is advanced, there is an increased airway space and patient gets a relaxed and easy way to breathe. We can plan maxillomandibular advancement with the help of other department. If surgical, it is known as distraction osteogenesis. If non-surgical, we have got some devices for that. We'll be going around with that now. So since the tools of an orthodontist is that they are trained in managing craniofacial region, routinely involved in clinical examination, we are well versed to read the lateral cephalogram and assess the airway space. We do have a range of devices to be utilized right there in our clinics on a day-to-day basis. That is why it becomes more important for an orthodontist or a dentist to be trained and be aware of how to diagnose a sleep apnea case. Very easily, when the moment the patient comes to a clinic, we can check for dryness of mouth. We can see the patient is sleepy or not. Is there soreness of mouth? And does the patient have mouth breathing? Here, mouth breathing is a very, very common thing that we ask for every patient. We check for every patient, be it adult or a children. Because it gives us an idea, helps us to plan a treatment, and thereby deliver an appliance. The American Academy of Sleep Medicine has recommended certain things. For example, sleep medicine physicians should consider prescription of oral appliances. So the advantage that we have got, first thing is that we have an appliance which is a non-surgical device for obstructive sleep apnea, and it's not new. It is aimed at opening up the airway for breathing comfort. Secondly, it is economically viable, as you mentioned earlier. Our main aim is to open the airway space for breathing comfort, and that's what we do with these devices. As early as 1982, it was given, a TRD device was given, which was given by Cartwright. It was a tongue retainer device, wherein the mandible was brought forward and the device consisted of a hollow bulb attached to two trays here. As you can see, the tongue was supposed to be placed in this open area. That was one attempt. Next came in the preformed silicone appliances, called the advancement of that same thing. It was a preformed silicone appliances, whereas you can see here, the tongue goes inside that device and holds the tongue there at night while sleeping, so that the tongue does not fall down and blocks the airway, thereby keeping the airway open during the sleep. Then there were devices like this, which is called a tongue repositioning maneuver, uses the oral shield. This is the oral shield, called the membrane funnel or the oral shield, used in 2007. Then we come in with the mandibular advancement device known as the MAD. What it does is it elevates the base of the tongue, it tenses the palatoglossus muscle and pulls the soft palate forward. It decompresses tissues around the pharynx and allows the pharynx to expand. This is done by the mandibular advancement device, which I'll be showing here. As we can see here, there's a mandibular advancement splint having an airway. You see, this splint is a custom-made device which is worn by the patient at when he or she is sleeping. It primarily holds the lower jaw, the mandible, anteriorly so that the base of the tongue also moves anteriorly. This is one device. Second is the biodata device. This is also, and I would like to tell here, these devices are commonly used by orthodontists on a day-to-day basis. And even dentists who has got an interest in orthodontics has gone through this, maybe have made it in their curriculum also. This is a bionator. It helps in keeping the mandible forward. A simple device, well accepted by the clients. Then we have got the activator appliances here. Here there's a twin block appliance over here. This is a very common device. We use it for growth modification in a growing child, and it certainly helps in keeping the mandible forward. And of course, there's the MAD device are titratable, and thereby if we can customize it as per the patient's need. Here in the lateral cephalogram, if you can see here, the medical dental sieve appliance, which was it is called MDSA. This was given in Dental Clinics North America Journal in 2001. So it's a long history there. As you can see, once the device is in place, the mouth is open and the mandible is placed forwardly. At the end of 6 months here, the whole scenario has changed. The airway over here, as if you can notice from the first cephalogram to the third cephalogram, there's an increase in airway space, thereby helping the patient. So the role of functional appliance is as follows. The functional mandibular advancement induces change in position and makes the mandible to be placed in a more forward position. It creates a new position for suprahyoid musculature, which in turn favors an increase in volume of the upper airways. That is the role of the functional appliance. So how does a dentist or an orthodontist fabricate the mandibular advancement device? Primarily, the basic starts here, diagnosis and treatment planning, taking an impression of the jaws or a scanning of the jaws, making a wax bite, sending to our labs, doing the necessary corrections, and then deliver to the patient, followed by follow-up. This is the first is the diagnosis and treatment planning. Then bite recording, as we can see in this slide, bite recording is being done with a modeling wax and bite gauge. Then the articulation of the models with recorded bite is being done. Then this model is transferred on a semi-adjustable articulator, and then the fabrication starts. The fabrication starts with the help of a thermoplastic material, which is mostly acrylic material. It can be heat cure or a cold cure material. Best works is the thermoplastic material. Of course, there's a limitation of mandibular advancement devices. First is there's need to acclimatize because it's a removable device and the patient can easily keep it off, throw it off, and does not use it, does not want to use it. Then, what is the maximum dose of mandibular advancement that has to be controlled in sleep apnea? That can be done with the lateral cephalogram study and a model analysis that an orthodontist is well versed with. then certainly there lies some uncertainty about the influence of appliance design on treatment outcome, and adverse effects are certainly probable. But as far as my experience, it has not been that way. Most patients have accepted the treatment. At the same time, potential long-term complication of therapy with respect to TMJ and occlusion will be there. There is a possibility because we are advancing the jaw, and they might lead to some TMJ problems and disturbance in the occlusion. For that, for these limitations, we have to be careful how to overcome the limitation. We have to give time for acclimatization of the patient with the device. There's certain need of titration to be done. More research has to be induced in this topic. We have to plan in early phases when we give the devices to avoid long-term complications. As at this time, the subject of OSA in pediatric and adult population is not included in the curriculum of most dental school, but gradually it is being introduced. It is a matter of which has to be taught with proper endorsements and qualifications. It's a supremely experienced and specialized thing and needs experience, of course. There's a need to standardize the curriculum, which needs to be developed and incorporated in all PG and UG programs. With that, I come to the summary part of today's topic. First is orthodontists to consider the incorporation of obstructive sleep apnea screening into their daily history taking and examination of patients. You may talk to your orthodontist, you may educate orthodontists across the country and globe. You may educate the orthodontists and dentists in your city, in your towns. How can they elicit, how can they see, diagnose, and refer the patients to you if need be, or primary management they can do. Yes, the orthodontist needs to work with the pulmonologist and other experts. And if there is a suspicion, suspicion to treat that I can't treat the patient, it has to be definitely referral has to be done. At certain times, it so happens that the OSA diagnosis is done by the physician and sent to me, and I make the devices and make the patient at comfort. Then there are individual orthodontists who may elect to participate in the treatment and monitoring of OSA patients. It is up to the orthodontist or the dentist to bring upon yourself to train and be part of interdisciplinary care of an OSA patient. With that, I come to the end of the seminar for today. These are references that I have used in my presentation. Some references which you see here, those slides have been omitted because it was already presented in the earlier presentations. So let's take one step forward from now. Thank you all for your patience hearing. Dr. Nurul. Hello.
Yeah, thanks,
Dr.
Sahu. Yeah.
Yes.
Thanks, Dr. Anshu Sahu, for giving the role of dental surgeon, because dentist and more precisely orthodontist is the integral integral part of the team who is handling and managing the OSA patients and all. It's a very important that there are the devices which is being and there are multiple innovations through which they can increase the airway and all with various devices and all. From audience, anybody want to ask any question to Dr. Anshu Sahu? Because you guys are also referring your patient to orthodontist for particular like mandibular advancement devices, etc. for making the air better airways and all.
It is a good referral thing. It's a good referral thing which both of the parties will benefit out of it. Not only the orthodontist or the dentist, as well as the sleep medicine specialist, the pulmonologist, the ENT specialist. So it's a mutual thing. Both of us can benefit with it and deliver better results for our clients. Well, sir.
So nice presentation, enlightening presentation, and you have complete make the all aspects of this, that how to treat this OSA patient and all. Thanks again for joining us today, sparing your time, and also I'm thankful to you for giving your time and managing the things as an organizing secretary.
Thank you, sir. I thank your all the organizing team, and I wish all the best to us all. And I thank the attendees today. Thank you, sir.
So thanks, Dr. Sahu. So before we are signing off for the day, we are having the announcement today for tomorrow. We have a certain announcement, like today we have listened multiple specialists, like we have heard ENT surgeon, neurologist. There are two neurologists joined, one from All India Institute of Medical Sciences, New Delhi, and one is SCMIT from Trivandrum. And there are multiple other speakers, those who are the clinicians, the internal medicine experts. Then we have one person who is from Ayurveda. He also joined in. And then we have two physiologists who have spoken about the sleep incidents and all. So tomorrow we have 7 speakers.
Hello, sir. Sorry to interrupt.
Yes.
I have one question. Sir, that mandibular advancement device, as you have shown in the slides, how it is recommended to wear for how many months or duration of the time?
Yes, with the permission of Dr. Nurul, I'll answer that question.
Go ahead.
Yes, sir. The recommended time is the night time, where especially we are recommending it to a patient initially 2 hours, because it is not a easy fit. It's a good fit, but to adapt to the device, it's a large device, and it takes time for the client to get adjusted to that device. So initially we tell the patient for 2 hours and gradually increase it to at least 14 hours usage.
Okay.
Because reason being, in a child, the child sleeps maximum of 8 hours, 9 hours. So at the time of sleeping, one, he or she has to wear that. Secondly, in the daytime, if he or she is watching TV or reading a book, at that time also we recommend to be used. So maximum 12 to 14 hours maximum. Whereas in adult, we are advocating it to be used only while sleeping at night time. 14 hours is maximum. Minimum is 8 hours. While lying down is basic. And if we even in supine position, that device we are advising.
Yes, sir. Thank you, sir.
Thank you, sir.
Thanks, Dr. Sahu, for clearing the query of Dr.
Thank you.
Yeah. Anyone else who want to ask question to Dr. Sahu? So no questions. So let me. I was giving you the idea of the tomorrow's agenda. We have 2 physiologists, 2 psychiatrists, 2 pulmonologists, and 1 orthodontic surgeon joining from different part of India. We have physiologist Dr. Arpita Priyadarshini. She would be joining from Tangi, Odisha, and Dr. Anamika Singh. She is a professor in Uttar Pradesh University of Medical Sciences, Safai. Then we have 2 prominent psychiatrists. One is Dr. Nishant Goyal, who is a professor in Central Institute of Psychiatry, Kanke, Ranchi, Jharkhand. And there is one more psychiatrist, Dr. Saurabh Das. He would be joining from Kolkata. And we have 2 very prominent speaker in the sleep medicine, Dr. Sanjay Manchanda. I think people know him very well. He is a chairman in the Department of Sleep Medicine, Sir Gangaram Hospital, New Delhi. And then we have Dr. Gopal Rawal. He is a pulmonologist, Shield Chest Disease Center, Ahmedabad. She would be joining tomorrow. And then Dr. Reena Ranjit Kumar. She is Academic Director in Eye and Care. Just Dr. Sahu was referring. So these are the prominent galaxies of speakers and stars who would be delivering their talk tomorrow. So requesting you to join at 11 tomorrow. I think the same link would be working tomorrow. So same link, same email will work tomorrow as well. So you join on time. And there's one more announcement that you would be getting your e-certificates for this presentation after the completion after completion of this whole webinar, maybe on Tuesday or Thursday. So our IT team and designing team is working on that, and they will upload it. You will easily get from the same website, ismcon.in. So with this announcement, we are signing off for the day. If you would have any questions from organizing committee, you can ask question. Otherwise, we'll close for the day. Anyone want to ask question? So my number is there in the brochure as well. So if you have any queries related to the link, you would be getting the Zoom link or anything that's not working, just let me know, and we would be helping you out. And it would be a great enthusiasm I am seeing from the audience side that they join and they keep on they stuck with their seats and they are still with us. So it's a very motivating that sleep is very niche segment in India and it's emerging actually. Though it's gradually and slowly, but it will establish in a future to come where multiple in every tertiary or quarterly care hospitals you will be getting one section especially dedicated to sleep. Now we are a very handful of tertiary care hospitals where sleep medicine department is dedicated and have a separate division. Either they are attached with either a pulmonology or with ENT surgeon or other departments, but very soon we would be getting in all places in India that there's a dedicated sleep division. So with this announcements, I'm signing off for the day and we'll join again tomorrow at 11 in the morning. Yeah, happy weekend. Thank you. Thanks all for joining. We are signing off. Thank you.